Primary headache is a type of headache that is not caused by another condition or injury. The underlying pathophysiology is not well understood, but it involves release of neurotransmitters such as calcitonin gene-related peptide in migraines and increased sensitization of pain pathways, including sensory inputs from the trigeminal and upper cervical nerves. The most common types of primary headache are tension-type headache, cluster headache, and migraine. Now, if a patient presents with a headache, you should first obtain a focused history and physical examination, including a fundoscopic exam. History typically reveals a patient younger than 50 years of age who reports episodes of recurrent headaches that are similar in quality and progression and completely resolve between attacks. They also report that the intensity of headaches doesn't require regular use of painkillers. Primary headaches are not positional, meaning that the quality of the headache does not change with positioning, such as when the patient is lying down versus standing up. Also, the headache is not worse with Valsalva maneuvers, such as sneezing, coughing, or straining for a bowel movement, or with jaw movement, such as chewing or talking. While obtaining history, be sure to rule out secondary causes of headaches. First, ask the patient if they have started any new medications recently, because some headaches can be an adverse effect of medications. Also, the patient should report no history of head trauma, systemic symptoms such as fever, malignancy, or immunodeficiency. If any of these are present, think of secondary headaches. Finally, the physical exam reveals a normal neurologic exam in between episodes of headache, with normal appearance of the optic nerves on the fundoscopic exam. With these findings, diagnose a primary headache. The next step is to ask your patient about the laterality of their headaches. If their headaches are bilateral, suspect tension-type headaches and assess the criteria for tension-type headaches. This type of headache can last minutes to days and must meet at least two of the following four characteristics. First, these headaches are associated with a pressing or tightening sensation. Sometimes your patient will describe this feeling as having a non-pulsating band of pressure around the head. Next, headaches should be bilateral and mild to moderate in intensity, but they should not worsen by routine physical activity, such as walking. Finally, tension-type headaches are usually not associated with nausea, vomiting, photophobia, or phonophobia. However, some patients might present with either photophobia or phonophobia, but not both. If your patient meets these criteria, diagnose tension-type headaches. Management of all primary headaches, including tension-type headaches, should start with lifestyle modifications, such as stress reduction, improved sleep schedule, adequate hydration, and regularly scheduled meals. Also, encourage the patient to track their headaches and use a diary to identify potential stressors and triggers. During an acute episode of a tension-type headache, options for abortive medications include nonsteroidal anti-inflammatory drugs, or NSAIDs, aspirin, acetaminophen, and caffeine. For patients with frequent episodes, consider starting a preventive medication. Options include tricyclic antidepressants such as amitriptyline and serotonin norepinephrine reuptake inhibitors, SNRI, like venlafaxine. All right, let's go back and focus on individuals who report unilateral headaches. In this case, you should suspect migraine or cluster headaches, so your next step is to assess whether the headache is associated with either restlessness or ipsilateral autonomic features, such as lacrimation or rhinorrhea. If either of those characteristics is present, suspect cluster headaches and assess the criteria to confirm the diagnosis. The patient should describe headaches as severe, unilateral pain in the orbital, supraorbital, or temporal region that lasts 15 minutes to 3 hours. These headaches are frequent and occur at least every other day, sometimes multiple times a day. Headaches should be associated with restlessness or agitation, causing the patient to pace around or rock back and forth in a chair during an episode, and or at least one of the ipsilateral autonomic features. These include conjunctival injection or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead and facial sweating, and miosis or ptosis. If the patient meets these criteria, diagnose cluster headache, which falls under a broader category of headaches known as trigeminal autonomic cephalalgias. The term cluster is used because patients tend to have clustered headache attacks that last for weeks to months, with periods of remission in between. Interestingly, most patients have a circadian pattern to their headaches, with symptoms starting around the same time each day. Management involves lifestyle modifications. Some known triggers for cluster headaches include alcohol, nitroglycerin, and heat. So patients should avoid these triggers. Acute headache treatment involves oxygen administration and triptans, such as subcutaneous or nasal sumatriptan or nasal zolmitriptan. To bridge the patients until preventive medications kick in, you can use corticosteroids orally or as an injection, targeting the greater occipital nerve. Finally, preventive medications include verapamil, lithium, and galcanezumab, which is a monoclonal antibody against the calcitonin gene-related peptide receptor or the CGRP receptor. Now, let's go back and look at individuals with unilateral headaches reporting no restlessness or ipsilateral autonomic features. In this case, suspect migraine headaches and assess whether your patient meets the criteria for migraines. Migraines last hours to days and have at least two of the following four features. First, they are unilateral in location. Second, they have pulsating quality. Third, they have moderate to severe pain intensity. And fourth, headaches are worsened by or cause avoidance of routine physical activity such as walking. Finally, in contrast to tension-type headaches, migraines are associated with nausea, vomiting, photophobia, and phonophobia. If your patient meets the criteria, diagnose migraines. Next, assess for the presence of auras. Think of auras as a warning sign of a migraine. They can be alterations in vision, sensation, speech, motor strength, and even level of consciousness. Auras most commonly involve vision, so your patient will usually describe seeing flashes of white or different colors. Also, they might report zigzag lines or a blind spot with a wavy, shimmering border known as a scintillating scotoma. If there are no auras, diagnose migraine without aura. On the flip side, if auras are present, then diagnose migraine with aura. Here's a high-yield fact to keep in mind. Migraines are more common in biological females, and for many individuals, they get worse in the perimenstrual period. Smoking and use of estrogen-containing oral contraceptives increase the risk of stroke in those with migraine with aura. In general, treatment for migraines with or without aura is the same. As before, encourage lifestyle modifications. Triggers for migraines include lack of sleep, strong smells, and dietary items such as chocolate, cheese, and alcohol. Migraine attacks are also associated with menstruation. As far as medical therapy goes, there are various pharmacological options for abortive migraine treatment. Non-specific medications include NSAIDs, aspirin, acetaminophen, and caffeine, as well as antiemetics like prochlorperazine and metoclopramide. In the emergency room, a popular NSAID to give is ketorolac because you can administer it intravenously. Migraine-specific medications include triptans, CGRP receptor antagonists known as gepants, a serotonin receptor agonist called lasmiditan, and dihydroergotamine, which is a nasal spray. You should avoid triptans and dihydroergotamine in patients with cardiovascular conditions because they can cause vasoconstriction. There is also a wide variety of options for preventive migraine treatments. Some examples include antihypertensives such as beta blockers and candesartan, antidepressants like amitriptyline and venlafaxine, and anti-seizure medications such as sodium valproate and topiramate. If patients do not respond to these medications or have contraindications to use them, try CGRP monoclonal antibodies like Erenumab and Galcanezumab, or CGRP receptor antagonists such as Atogepant and Rimegepant. Finally, for patients with chronic migraines that are refractory to the previously mentioned medications, consider Botox injections, more specifically Onabotulinum toxin A. Here's a clinical pearl. Migraines in children commonly involve bilateral frontal and temporal regions. In addition, children may present with childhood periodic syndromes, including abdominal migraine, which is recurrent abdominal pain that lasts hours to days. All right, as a quick recap, tension-type headaches are usually bilateral and mild to moderate in intensity. If headaches are unilateral, consider cluster headaches or migraines, which are more severe in intensity. Cluster headaches are associated with restlessness or ipsilateral autonomic features, while migraines are not. Finally, the management of primary headaches includes lifestyle modifications and medical treatment with abortive and preventive medications.
Acute dyspnea is the sensation of difficult or uncomfortable breathing that develops over hours to days. Dyspnea is a common symptom with a wide range of causes, including respiratory, cardiovascular, metabolic, neuromuscular, and neurologic conditions. Many causes of acute dyspnea are life-threatening, so it's important to have a systematic approach to evaluating these patients. When approaching a patient with dyspnea, first you should perform an ABCDE assessment to determine if your patient is unstable or stable. If they are unstable, first check for alarm signs and symptoms. Check for upper airway obstruction by auscultating for stridor, a high-pitched breathing sound, and by directly examining the airway for oropharyngeal swelling or the presence of a foreign body. If the airway is clear, evaluate the patient's breathing by assessing respiratory rate and oxygen saturation. A respiratory rate less than 10 or greater than 20 breaths per minute, or oxygen saturation at less than 90% requires acute management. You should also look for red flag features that signal impending respiratory failure, such as confusion, inability to speak in complete sentences, and the use of accessory respiratory muscles such as the scalenes and intercostals. In this case, stabilize the airway, breathing, and circulation, which may require removing any airway obstruction, endotracheal intubation, and mechanical ventilation. Some patients might require supplemental oxygen only, but in both cases, don't forget to obtain IV access and put your patient on continuous vital sign monitoring. Now, here's a high-yield fact to keep in mind. Causes of acute airway obstruction that might present with stridor include anaphylaxis, epiglottitis, and the presence of a foreign body. Suspect anaphylaxis if the patient reports exposure to a known allergen, such as an insect sting. and presents with urticaria, stridor, or wheezing. On the other hand, epiglottitis most commonly presents with hoarseness and dysphagia in the setting of upper respiratory infection caused by Haemophilus influenzae, as well as streptococcal and staphylococcal species. Finally, the presence of a foreign body is usually via accidental aspiration and can range from a child that inhaled a small toy to an unconscious patient that has vomited and obstructed the airway. Now that unstable patients are taken care of, let's go back to the ABCDE assessment and take a look at stable patients. If your patient is stable, proceed with a focused history and physical examination and order labs, including CBC, BMP, BNP, D-dimer, and cardiac enzymes. Additionally, order imaging, like a chest X-ray, and possibly point-of-care ultrasound, or POCUS for short. You'll also want to get an ECG on all patients with dyspnea. First, let's discuss the primary respiratory causes of acute dyspnea, which include pneumothorax, pneumonia, asthma, and COPD exacerbation. Let's look at pneumothorax. Consider pneumothorax in a patient with acute dyspnea that reports pleuritic chest pain. On physical exam, decreased breath sounds and hyperresonance to percussion on the affected side are consistent with pneumothorax. Chest X-ray will show a distinct visceral pleural edge with an absence of distal lung markings, and in the case of a tension pneumothorax, may show tracheal deviation and mediastinal shift away from the side of the collapsed lung. POCUS will show absent lung sliding. Keep in mind that patients with tension pneumothorax are usually unstable, so you should skip imaging and perform immediate needle decompression. Another primary respiratory cause of acute dyspnea is pneumonia. A person with pneumonia might report pleuritic chest pain, productive cough, and fever. Their labs will show leukocytosis with left shift, while chest X-ray could show lobar consolidation or diffuse infiltrates. Common POCUS findings include subpleural consolidation, liver-like echogenicity of the lung, and dynamic air bronchograms. All of these findings are suggestive of pneumonia. Next, let's look at obstructive lung disease as a cause of acute dyspnea. Bronchoconstriction during an asthma or COPD exacerbation can cause wheezing, diminished air entry, and a prolonged expiratory phase on physical exam. Chest X-ray may show lung hyperinflation and flattened diaphragms. History can help distinguish between asthma and COPD. Patients with asthma are typically younger and have episodic dyspnea triggered by allergens or exercise, but breathe normally between episodes. Individuals with COPD tend to be older, often have a productive cough that worsens over time, and have a history of smoking. Next, let's move on to cardiovascular causes of acute dyspnea, which include cardiac tamponade, pulmonary embolism, myocardial infarction, arrhythmia, and decompensated heart failure. Let's start with cardiac tamponade. In these individuals, history finding typically includes chest pain, and the physical findings include pulsus paradoxus and Beck triad, which is hypotension, jugular venous distension, and muffled heart sounds. ECG often shows sinus tachycardia with low-voltage QRS complexes or electrical alternans. Chest X-ray might reveal a widened mediastinum and a water bottle sign, where the cardiac silhouette appears enlarged and stretched. Diagnosis of cardiac tamponade can be confirmed via POCUS or transthoracic echocardiogram, or TTE, which typically shows pericardial effusion as well as diastolic collapse of the right atrium and ventricle. Next up is pulmonary embolism. Suspect pulmonary embolism in patients with pleuritic chest pain and hemoptysis that have a history of deep vein thrombosis, or DVT. Chest X-ray is usually normal. On the other hand, ECG often shows sinus tachycardia, and less frequently the S1Q3T3 pattern, where there's a large S wave in lead 1 and a Q wave and inverted T wave in lead 3. Since massive PE causes strain to the right heart, labs may show elevated cardiac enzymes. The likelihood of PE can be determined by the Wells criteria. A high probability Wells score or an intermediate score plus elevated D-dimer should prompt you to order CT pulmonary angiography, or CTPA. If the CTPA reveals a filling defect in a pulmonary artery, the diagnosis of pulmonary embolism is confirmed. Another important cardiac cause of acute dyspnea is myocardial infarction. Suspect myocardial infarction in a person with risk factors for cardiovascular disease who presents with anginal chest pain and diaphoresis. ECG might reveal ST segment elevations or depressions, T-wave inversions, and new onset left bundle branch block, while labs will usually show elevated cardiac enzymes from myocardial damage. All of these findings are suggestive of myocardial infarction. Next, let's look at arrhythmia. Let's suppose a dyspneic patient presents with palpitations or syncope. In this case, consider arrhythmia as the cause of their symptoms. On exam, you may detect bradycardia, tachycardia, or an irregular pulse. The ECG may show a bradyarrhythmia, like heart block, or tachyarrhythmia, like atrial fibrillation, with rapid ventricular response. On the other hand, if the cardiac rate and rhythm are normal, consider a paroxysmal arrhythmia and start cardiac rhythm monitoring to catch the next episode. Finally, let's not forget acute decompensated heart failure that leads to pulmonary edema. This occurs because the heart isn't pumping blood efficiently, so it backs up into the pulmonary vein and capillaries. As the pressure increases, fluid is leaked from the pulmonary capillaries into the alveoli, leading to pulmonary edema. These individuals may also complain of chest discomfort and orthopnea. Physical exam will typically reveal jugular venous distension, or JVD, rales, and lower limb swelling with pitting edema, while labs usually show an elevated BNP. Chest X-ray often reveals pulmonary edema or even pleural effusion. In this case, order TTE to detect ventricular dysfunction, which supports the diagnosis of acute decompensated heart failure. Here's a high-yield fact. Not all pulmonary edema is caused by heart failure, so in those cases, you won't see ventricular dysfunction on TTE. Some important causes include acute respiratory distress syndrome, or ARDS, and severe renal failure. ARDS is characterized by increased permeability of the pulmonary capillaries due to severe inflammation, which can be triggered by conditions like sepsis, pancreatitis, or aspiration. On the other hand, patients with severe renal failure have impaired excretion of water and solutes, which in turn leads to hypervolemia or fluid overload. Okay, if both respiratory and cardiogenic causes are unlikely, consider metabolic acidosis. This is because when there's a buildup of acid from excess creation or inability to excrete, the body's reaction is to stimulate the respiratory center in the brainstem. As a result, patients develop hyperventilation to compensate for the acidosis by getting rid of more CO2, which is also an acid. Now, metabolic acidosis can have multiple causes, such as excessive alcohol intake or starvation, while two causes that you need to keep in mind first are diabetic ketoacidosis and salicylate toxicity. First, let's start with diabetic ketoacidosis, or DKA for short. DKA can trigger compensatory hyperventilation and cause shortness of breath. Suspect DKA in a person with a history of diabetes mellitus, or DM, who complains of polyuria and polydipsia. On exam, they may show signs of dehydration like dry mucous membranes and poor skin turgor and have a fruity odor to the breath. Labs will show hyperglycemia, ketonemia, and metabolic acidosis with an elevated anion gap, and ABG will confirm metabolic acidosis and thus confirm the diagnosis of diabetic ketoacidosis. Next, let's look at salicylate toxicity. Salicylate toxicity is another metabolic disturbance that can present with acute respiratory symptoms. People who ingest toxic levels of salicylates develop tachypnea due to increased respiratory drive. These individuals often report salicylate ingestion and present with tachypnea. When evaluating a patient with suspected salicylate toxicity, labs will show metabolic acidosis with an elevated anion gap. Next, check an ABG and serum salicylate level. The presence of metabolic acidosis with respiratory alkalosis is commonly observed in salicylate toxicity, while an elevated serum salicylate level confirms the diagnosis. Finally, let's take a look at neuromuscular and neurogenic causes of acute dyspnea. First, let's look at neuromuscular disease. Neuromuscular conditions like myasthenia gravis and Guillain-Barré syndrome are uncommon but important causes of respiratory distress to consider, particularly if the patient reports a history of neuromuscular disease or displays signs of neurologic dysfunction, like muscle weakness, dysarthria, dysphagia, or ineffective cough. Checking an ABG will typically reveal respiratory acidosis in patients with dyspnea due to neuromuscular disease. Lastly, let's look at acute anxiety and panic disorder. Acute anxiety and panic disorder are psychiatric causes of acute dyspnea that may present during an anxiety-provoking event, such as witnessing an accident, or in the absence of an obvious stressor, like during a panic attack. However, this is a diagnosis of exclusion that should be considered only after other, more life-threatening causes have been ruled out. An individual with dyspnea due to anxiety may report associated symptoms of chest tightness, palpitations, and sweating. Laboratory tests and imaging will be negative for other causes of dyspnea. Using a validated metric, like the 7-question General Anxiety Disorder or GAD-7 questionnaire, can help you confirm the diagnosis. All right, as a quick recap, acute dyspnea is a common symptom in a variety of respiratory, cardiovascular, metabolic, neuromuscular, and neurologic problems, many of which are life-threatening. Approach the evaluation of a patient with dyspnea systematically so that you don't miss an important diagnosis. Start with assessing the airway for obstruction. Next, consider respiratory conditions including pneumothorax, pneumonia, as well as asthma and COPD exacerbations. Next, evaluate for cardiovascular causes of dyspnea, such as cardiac tamponade, pulmonary embolism, myocardial infarction, arrhythmia, and acute decompensated heart failure with pulmonary edema. If respiratory and cardiovascular causes have been ruled out, think of causes of metabolic acidosis, such as excessive alcohol intake or starvation, as well as diabetic ketoacidosis and salicylate toxicity. And finally, consider neuromuscular and neurogenic problems, including neuromuscular disease and acute anxiety.
Anxiety disorders are conditions characterized by excessive fear and anxiety. Fear is an emotional reaction to a threat, either real or perceived, and is usually associated with autonomic arousal. Anxiety, on the other hand, is the anticipation of a future threat. It's not usually associated with autonomic arousal, and it often causes maladaptive changes in thinking or behavior. Distinguishing between the various anxiety disorders requires identifying the triggers that set them off, any related changes in thinking or behavior, and assessing the Diagnostic and Statistical Manual, or the DSM-5 criteria. Common anxiety disorders include panic disorder with or without agoraphobia, obsessive-compulsive disorder, or OCD, specific phobias, social anxiety disorder, and generalized anxiety disorder, or GAD. When a patient presents with a chief concern suggesting an anxiety disorder, first perform a focused history and physical examination. Your patient will report excessive fear or anxiety, or sometimes both. In some cases, they might also report chest discomfort. The physical exam might show restlessness, a tense or constricted affect, tachycardia, or elevated blood pressure. With these findings, consider an anxiety disorder and investigate further to determine the specific type. Let's start by assessing for a history of panic attacks. A panic attack is an abrupt period of intense fear, accompanied by an uncomfortable surge of autonomic arousal, where the heart beats faster, respirations increase, and muscles tense up. Patients might report trembling, sweating, chest discomfort, palpitations, shortness of breath, nausea, paresthesias, or lightheadedness. Additionally, there might be associated emotional symptoms like crying, dissociation, feeling out of control, or fear of dying. Panic attacks can be triggered by stressful situations or can occur unexpectedly. Here's an important clinical pearl. An acute panic attack can present like acute coronary syndrome, with symptoms such as diaphoresis, chest discomfort, and shortness of breath. With this presentation, be sure to evaluate for cardiac causes. This is especially recommended if it's a patient's first episode or if there are any risk factors for cardiovascular disease. In this case, order cardiac enzymes and a 12-lead ECG. If it's a true panic attack, cardiac enzymes will be unremarkable and the ECG will show no signs of ischemia. Now, if your patient experiences recurrent panic attacks, consider panic disorder. To confirm the diagnosis, assess the DSM-5 criteria, which specify that they must have repeated, unexpected panic attacks. Also, they must experience at least 1 month of nearly constant worry about future episodes, or make maladaptive changes to their behavior to avoid having attacks, or both. If these criteria are met and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose panic disorder. Here's a clinical pearl to keep in mind. Certain medical conditions can cause symptoms resembling panic attacks. These include hyperthyroidism, hyperparathyroidism, seizures, and pheochromocytoma. Additionally, certain medications such as steroids, stimulants, and similar drugs of abuse can trigger these symptoms. So keep an eye out for these possibilities during your assessment. Okay, once you've diagnosed panic disorder, your next step is to determine if agoraphobia is present. Agoraphobia refers to fear or anxiety about situations, such as using public transportation, being in open spaces like a parking lot, being in enclosed spaces like a theater, standing in line or being in a crowd, or being alone outside of their home. Your patient will report avoiding situations like these or endure them with extreme anxiety due to fear that they'll be unable to escape or that there's no help available if something terrible happens, like visibly panicking or becoming embarrassed. The amount of anxiety they experience will be out of proportion to the actual danger these situations pose to them, and it will impair their ability to function in important areas of life, like social or occupational contexts. If agoraphobia has been persistent for at least 6 months and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose panic disorder with agoraphobia. Otherwise, diagnose panic disorder without agoraphobia. Here's another clinical pearl to keep in mind. Agoraphobia is typically diagnosed in association with panic disorder, but it can occur independently. For instance, an elderly person may develop agoraphobia associated with the fear of falling or having incontinence outside the home, but without associated episodes of panic. In this case, agoraphobia can result in problems like missing important medical appointments or becoming socially reclusive. Now, let's look at when your patient reports infrequent or no panic attacks. In this case, your next step is to assess for the presence of obsessions and compulsions. Obsessions are recurrent, intrusive thoughts that can manifest as images or urges that cause significant anxiety or distress. On the other hand, compulsions are ritualized attempts aimed at alleviating the anxiety caused by obsessions. The content or subject of obsessions and compulsions can vary from patient to patient, and common themes include contamination, symmetry, or danger. And here's another clinical pearl. Compulsions can manifest as either mental or behavioral acts, often unrelated to the obsession in a realistic manner. Examples of compulsions include excessive hand-washing, arranging or ordering items, counting, repeating words or phrases, or repeatedly checking locks. Now, if obsessions or compulsions are present, consider obsessive-compulsive disorder, or OCD for short. Next, assess whether your patient meets the DSM-5 criteria for OCD. In addition to obsessions, compulsion, or both being present, the symptoms must take up a significant amount of time, impair their ability to function, or cause significant distress. If these criteria are met, and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose OCD. Now, let's discuss patients with no obsessions or compulsions. In this case, your next step is to assess for other specific triggers causing your patient's anxiety. If your patient describes a single, specific situation or object that provokes immediate fear or anxiety, consider specific phobia and assess the DSM-5 criteria. Here, the fear or anxiety persists for at least 6 months, and it must be out of proportion to the actual danger posed by the situation or object. Also, they'll either actively avoid the situation or object, or endure it with intense anxiety. Finally, the fear or anxiety must cause significant distress or impair their ability to function. If these criteria are met and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose specific phobia. Here's another clinical pearl to keep in mind. It's quite common for an individual to have more than one specific phobia, which would be separate comorbid diagnoses. There are 4 main categories of triggers: animals like spiders or dogs, natural environments like heights or storms, situations like elevators or airplanes, or blood injection injury events like medical procedures and needles. Additionally, there are other miscellaneous phobias, such as fear of vomiting or fear of loud sounds. Okay, now let's look at when your patient's anxiety is triggered by social situations. In this case, you should consider social anxiety disorder. This form of anxiety is generally due to excessive fear or anxiety about social situations where they might be embarrassed or judged by others. To confirm the diagnosis, assess the DSM-5 criteria. The fear or anxiety must persist for at least 6 months, and it must be out of proportion to the actual threat posed by the situation. Also, they'll either actively avoid the social situation or endure it with intense anxiety. Finally, the fear and anxiety must cause significant distress or impair their ability to function. If these criteria are met, and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose social anxiety disorder. Here's another clinical pearl. Social anxiety can present in lots of ways, depending on the patient. Some patients avoid eating in public or using public restrooms to avoid potentially embarrassing situations. Others clam up at work due to fear of being judged as weak, offensive, or unlikable. Additionally, performance anxiety is a subtype of social anxiety and includes fear of public speaking or stage fright. Finally, let's have a look at when your patient has excessive anxiety and worry about routine situations such as finances, relationships, work or school performance, or health. With this presentation, you should consider generalized anxiety disorder, or GAD for short, and assess the DSM-5 criteria. To meet the criteria, your patient's anxiety and worry must be present more days than not for at least 6 months, and be associated with 3 or more of the following physical symptoms: restlessness, fatigue, poor concentration, irritability, muscle tension, or poor sleep. In addition, the anxiety and worry are difficult to control, cause significant distress, or impair their ability to function. If these criteria are met, and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose GAD. Here's one last clinical pearl to keep in mind. Similar to panic disorder, a few medical conditions and substances can mimic symptoms of generalized anxiety disorder. These include hyperthyroidism or pheochromocytoma, as well as stimulants like caffeine. If indicated by other history or exam findings, you should rule these out first. Alright, as a quick recap, anxiety disorders are conditions characterized by excessive fear or anxiety and can cause maladaptive changes to thoughts and behaviors. Panic disorder is diagnosed when a patient experiences repeated, unexpected panic attacks and pervasive fear about future panic attacks. Panic disorder can occur with or without agoraphobia. Obsessive-compulsive disorder, or OCD, is characterized by the presence of obsessions and compulsions. Specific phobia is triggered by a single, specific situation or object. Social anxiety disorder occurs when a patient primarily fears being embarrassed or judged in social environments. Finally, generalized anxiety disorder, or GAD, occurs when a patient worries about routine situations and has accompanying physical symptoms.
Asthma is an episodic, chronic respiratory disorder characterized by airway obstruction caused by inflammation and hyperresponsiveness of the bronchial smooth muscle. Asthma is reversible, which means the obstruction can virtually disappear with medications like bronchodilators, and inducible, which means the obstruction can occur in response to a variety of stimuli, including allergens, irritants, and respiratory tract infections. Clinical manifestations are highly variable, ranging from infrequent and mild symptoms that have minimal functional limitations to frequent acute asthma exacerbations causing significant impairment in functional capacity, and even life-threatening respiratory failure that's often referred to as status asthmaticus. Now, if you suspect asthma, you should first perform an ABCDE assessment to determine whether your patient is stable or unstable. If they're unstable, stabilize their airway, breathing, and circulation, obtain IV access, and begin continuous vital sign monitoring, including heart rate and blood pressure. Next, obtain focused history and physical, order labs, including ABG, and perform spirometry to assess the patient's peak expiratory flow, or PEF for short. Finally, don't forget to place your patient on pulse oximetry. History typically reveals shortness of breath, cough, and chest tightness. On the flip side, physical exam is likely to show tachypnea and use of accessory inspiratory muscles. In addition, auscultation can reveal bilateral wheezing due to inflamed and narrowed airways, and if the condition worsens, you may find decreased or even absent breath sounds since less air is reaching alveoli. Next, ABG might reveal arterial pH of 7.35 or less and PCO2 above 45 millimeters of mercury, indicating respiratory acidosis and hypercapnia, while spirometry usually shows PEF less than 40%. Finally, pulse oximetry might demonstrate saturation below 90%. If this is the case, suspect acute asthma exacerbation or even status asthmaticus, and immediately administer supplemental oxygen at 100% FiO2, inhaled bronchodilators, including a short-acting muscarinic antagonist like ipratropium, and a short-acting beta agonist or SABA like albuterol, as well as systemic corticosteroids, either oral or IV. If the patient doesn't respond to treatment, you can also give a single dose of IV magnesium. Lastly, in severe cases, you may even proceed with endotracheal intubation and mechanical ventilation, especially if your patient has altered mental status, cyanosis, or inability to maintain respiratory effort, as well as worsening hypercapnia and respiratory acidosis. Now, let's go back to the ABCDE assessment and discuss stable patients. First, perform a focused history and physical. Your patient is likely to report shortness of breath, coughing, and chest tightness, often triggered by allergens and exercise, and they may even have an existing diagnosis of asthma. On the other hand, physical examination often reveals tachypnea and wheezing. If this is the case, suspect asthma, or if your patient has already been diagnosed with asthma, suspect worsening of its severity. You'll want to monitor the patient's vital signs, including heart rate, blood pressure, respirations, and oxygen saturation. Finally, provide supplemental oxygen to maintain an oxygen saturation above 90%. The next step in patient management is to obtain spirometry, including FVC and FEV1, to confirm the diagnosis. FVC, or forced vital capacity, is the maximum amount of air a person can forcibly exhale from their lungs after a maximum inhalation, while FEV1 is the volume of air exhaled during the first second of this forced exhalation. Now, here's a clinical pearl to keep in mind. Spirometry can be performed with a simple handheld spirometer. First, have your patient take a maximal breath in, then forcibly exhale into the spirometer until all of the air is emptied from their lungs. This will generate a flow volume loop, which will differentiate between obstructive and restrictive patterns of lung disease. Now that you've completed spirometry, calculate the patient's FEV1 to FVC ratio. If the ratio is within normal range or even elevated for the patient's age, consider an alternative diagnosis. On the other hand, if the ratio is below normal range, suspect an obstructive lung disease, which includes asthma. But this is not enough to confirm the diagnosis, so your next step is to perform bronchodilator response or reversibility, or BDR testing. BDR testing consists of giving an inhaled dose of ASABA, followed by repeat spirometry, paying particular attention to the FEV1. If BDR testing reveals an improvement in FEV1 of 12% or more after SABA administration, you can make a confident diagnosis of asthma. On the other hand, if BDR testing reveals an improvement of FEV1 of less than 12% after SABA administration, then it's not considered significant. Still, to confidently rule out asthma, you'll need to perform further investigations, such as fractional exhaled nitric oxide testing, bronchial provocation testing, exercise challenge testing, or demonstration of peak expiratory flow variability on serial testing over the course of 2 weeks. If no reversibility of airway obstruction is evident on additional testing, consider an alternative diagnosis. However, if reversibility is present, then you can confidently diagnose asthma. Now, once you make the diagnosis of asthma, the next step is to assess symptom severity, which will help define the intensity of treatment. Based on asthma manifestations over the previous month, asthma symptoms can be classified as well-controlled, partly controlled, or poorly controlled. To determine the type, ask the following questions. First, ask your patient if they have been having daytime asthma symptoms more than twice per week. Next, determine if asthma symptoms have awakened them at night. Also, ask if they have been using a SABA inhaler to relieve asthma symptoms more than twice per week. Finally, ask your patient whether or not their asthma symptoms are persistent and limit their activities. Now, determine the intensity of treatment by the number of yes and no responses your patient gives to these questions. To start off, well-controlled asthma is when the answer to all of these questions is no. Patients with well-controlled asthma can be started on Step 1 or Step 2 therapies. Step 1 therapy is a low-dose inhaled corticosteroid, or ICS, and a long-acting beta agonist, or LABA, used in a combination inhaler known as an ICS-LABA as a reliever on an as-needed basis only. Step 2 therapy is an ICS used on a daily basis as a controller medication. No matter which option is chosen, ASABA is also commonly prescribed as a reliever medication. On the other hand, if your patient answers yes to one or two of these questions, their asthma is partly controlled. In this case, start your patient on Step 3 therapy, which consists of a low-dose ICS-LABA daily as a controller medication, with ASABA commonly prescribed as a reliever medication. Finally, if your patient answers yes to 3 or 4 of these questions, their asthma is poorly controlled, so you should start them on Step 4 or Step 5 therapies. Step 4 therapy is a medium-dose ICS-LABA used on a daily basis as a controller medication, whereas Step 5 therapy includes a high-dose ICS-LABA used on a daily basis as a controller medication. In severe cases, consider adding a long-acting muscarinic antagonist, or LAMA, or even biologic therapy. No matter which option is chosen, ASABA is also commonly prescribed as a reliever medication. Now, here's a clinical pearl to keep in mind. Asthma is a variable disease, meaning it can be triggered by many environmental variables and complicated by other risk factors and disease processes. These include smoking, exposure to smoke or other respiratory irritants, comorbidities such as allergic rhinitis and obesity, and prior asthma exacerbations in the past year. Sometimes asthma may even decompensate or even improve over time in the absence of an identifiable trigger. For these reasons, you should reassess your patient periodically, both clinically and by repeating spirometry. Okay, as a quick recap, if you suspect asthma, first you should determine whether or not your patient is stable or unstable. If they are unstable, suspect asthma exacerbation and immediately start your patient on supplemental oxygen, inhaled SAMA like ipratropium, and SABA like albuterol, and systemic corticosteroids. Unresponsive cases may get IV magnesium, while severe cases might require endotracheal intubation and mechanical ventilation. On the other hand, if your patient is stable, obtain spirometry and calculate the patient's FEV1 to FVC ratio. If the ratio is within the normal range or elevated, consider an alternative diagnosis. On the other hand, if the ratio is below the normal range, suspect an obstructive respiratory condition and proceed with BDR testing. FEV1 improvement of less than 12% requires further investigations. If additional testing reveals no reversibility of airway obstruction, consider an alternative diagnosis. However, if reversibility is present, then you can confidently diagnose asthma. On the other hand, if BDR testing reveals FEV1 improvement of 12% or more, you can also make a confident diagnosis of asthma. Either way, your next step is to assess the patient's symptom severity and determine the type of asthma. Individuals with well-controlled asthma should be started on Step 1 or Step 2 therapies. Step 1 therapy includes ICS-LABA on an as-needed basis only, while Step 2 is an ICS used on a daily basis. On the other hand, patients with partly controlled asthma require Step 3 therapy, which consists of a low-dose ICS-LABA daily. Finally, individuals with poorly controlled asthma should be started on Step 4 therapy, which includes medium-dose ICS-LABA, or Step 5 therapy, which includes high-dose ICS-LABA. In severe cases, consider adding a LAMA, or even biologic therapy. Finally, no matter which step is chosen, a SABA could also be prescribed as a reliever medication.
An acid-base disorder is any process that causes the arterial pH to move outside its normal range of 7.35 to 7.45. When the arterial pH decreases below this range, the process is called acidosis. On the other hand, if the pH increases above this range, then it's referred to as alkalosis. Now, depending on the cause, acid-base disorders can be classified as either respiratory or metabolic. Respiratory acid-base disorders are due to an increase or decrease in the removal of carbon dioxide from the body through the lungs. On the other hand, metabolic acid-base disorders result from the loss or accumulation of acids or bicarbonate. Now, if a patient presents with a chief concern suggesting an acid-base disorder, you should first perform an ABCDE assessment to determine if your patient is unstable or stable. If your patient is unstable, stabilize their airway, breathing, and circulation, which may require endotracheal intubation with mechanical ventilation. Next, obtain IV access and put your patient on continuous vital sign monitoring, including blood pressure, heart rate, and pulse oximetry. Finally, if needed, don't forget to provide supplemental oxygen. Now, let's go back to the ABCDE assessment and discuss stable patients. In this case, first obtain a focused history and physical examination and order labs, including a comprehensive metabolic panel or CMP and an arterial blood gas or ABG. The history will vary greatly depending on the type of acid-base disorder and the underlying cause. Your patient might report fatigue, nausea, and vomiting, or recent medication changes including diuretics or salicylates. The physical exam might reveal an abnormal respiratory rate, whereas the CMP might show electrolyte abnormalities depending on the type of the disorder, mainly involving bicarbonate, potassium, and chloride. Next, assess the arterial pH from the ABG results. If the pH is under 7.35, you can diagnose acidosis. Your next step is to determine whether the acidosis is either respiratory or metabolic, which involves assessing both the PCO2 from the ABG and serum bicarbonate level from the CMP. If the PCO2 is increased above its normal range, which is 35 to 45 millimeters of mercury, then that's respiratory acidosis. This means there's a process causing reduced carbon dioxide elimination through the lungs, such as a decreased rate or depth of breathing, or an impaired alveolar gas exchange. Here's a clinical pearl. Once you've diagnosed respiratory acidosis, evaluate for metabolic compensation by checking the serum bicarbonate level. Uncompensated respiratory acidosis will have a low pH and elevated PCO2, but with a normal bicarbonate level. On the other hand, if there is metabolic compensation, the bicarbonate level will be elevated because the kidneys are retaining it to restore normal pH. Now that we're done with respiratory acidosis, let's go back and take a look at bicarbonate. Normally, serum bicarbonate levels are between 22 and 27 milliequivalents per liter. If the bicarbonate level is decreased in addition to having a low pH, diagnose metabolic acidosis. Okay, here's some clinical pearls to keep in mind. After diagnosing metabolic acidosis, check the PCO2 to see if there's respiratory compensation. If the PCO2 is normal in the setting of low pH and low bicarbonate levels, your patient is experiencing uncompensated metabolic acidosis. If there's respiratory compensation, more CO2 will be expelled through the lungs by an increased respiratory rate or depth, so the PCO2 will be low. However, if you notice a high PCO2 in the setting of a low pH and low bicarbonate level, your patient is experiencing mixed respiratory and metabolic acidosis. For example, this might occur in a patient with diabetic ketoacidosis, a type of metabolic acidosis which can be associated with cerebral edema and subsequent central respiratory depression, hypoventilation, and respiratory acidosis. As you might expect, when two or more processes causing acidosis occur simultaneously, the pH is lower than you would expect from a single metabolic disturbance. Now, let's take a look at individuals with a pH between 7.35 and 7.45. In this case, your patient has a normal arterial blood pH. This could mean there's no acid-base disorder, or it could mean there's a mixed acid-base disorder, where two or more acid-base disorders coexist and offset each other. These patients may present with normal or only slightly abnormal pH in the direction of the predominant or more severe acid-base disorder. In this case, you should also check the PCO2 and bicarbonate levels. If both levels are normal, there's no acid-base disorder. However, if they're increased or decreased, suspect a mixed acid-base disorder with both acidosis and alkalosis existing together. One well-known example of a mixed disorder is salicylate toxicity, which initially stimulates the respiratory center in the brain, leading to hyperventilation and subsequent respiratory alkalosis, while at the same time disrupting aerobic metabolic processes, leading to the production of lactic acid, which ultimately leads to the development of metabolic acidosis. Alright, now that we've covered cases in which the pH is acidic and normal, let's go back to our ABG results. If the arterial pH is above 7.45, your patient has an alkalosis. Once again, your next step is to distinguish whether the alkalosis is respiratory or metabolic. To do so, assess PCO2 and serum bicarbonate levels. If the PCO2 is decreased, you can diagnose respiratory alkalosis. Here's a clinical pearl. After diagnosing respiratory alkalosis, check for metabolic compensation by assessing the serum bicarbonate level. An increased pH and low PCO2, along with a normal bicarbonate level, indicate that respiratory alkalosis is uncompensated. However, if bicarbonate is decreased, it means that there's metabolic compensation, so the kidneys are eliminating bicarbonate in an effort to lower the pH back to normal. Okay, let's go back and take a look at serum bicarbonate levels. Increased pH, along with increased serum bicarbonate levels, is suggestive of metabolic alkalosis. Here are some final clinical pearls to keep in mind. After diagnosing metabolic alkalosis, check the PCO2 to see if there's respiratory compensation. If the PCO2 is normal in the setting of an increased pH and elevated bicarbonate level, your patient is experiencing uncompensated metabolic alkalosis. However, if there's respiratory compensation, less CO2 will be expelled through the lungs by a decreased respiratory rate or depth, so the PCO2 will be high. Occasionally, you might see low PCO2 in the setting of increased pH and increased bicarbonate level. In this case, there's respiratory and metabolic alkalosis happening together. For example, someone may have hyperthyroidism, which leads to chronic hyperventilation and subsequent respiratory alkalosis, along with acute metabolic alkalosis from recent vomiting. This pushes the pH higher than it would be from either type of alkalosis alone. Alright, as a quick recap, when evaluating a patient with suspected acid-base disorder, first you need to determine the type of disorder by assessing arterial pH. Arterial pH less than 7.35 indicates acidosis, so your next step is to assess PCO2 and bicarbonate levels to determine if it's respiratory or metabolic. On the other hand, arterial pH from 7.35 to 7.45 is considered normal, so again, use PCO2 and bicarbonate levels to distinguish a normal condition from a mixed alkalosis and acidosis. Finally, arterial pH above 7.45 is considered alkalosis, so again, use PCO2 and bicarbonate to determine if it's respiratory or metabolic.
Metabolic acidosis refers to an increase in hydrogen ion concentration and a decrease in bicarbonate concentration in the blood. This can cause the pH to fall below 7.35 and serum bicarbonate level under 22 milliequivalents per liter. As a reference, bicarbonates normally range from 22 to 27 milliequivalents per liter. Metabolic acidosis can be classified as either normal anion gap metabolic acidosis, which occurs in conditions like renal tubular acidosis, or elevated anion gap metabolic acidosis, which is seen in conditions like ketoacidosis. If a patient presents with a chief concern suggesting metabolic acidosis, first perform an ABCDE assessment to determine if they are unstable. If your patient is unstable, stabilize their airway, breathing, and circulation. Next, obtain IV access, put your patient on continuous vital sign monitoring, and provide supplemental oxygen if needed. Here's a clinical pearl. Severe cases might present with nausea, vomiting, lethargy, and tachypnea, and might need treatment with hemodialysis. Let's move on to stable patients. First, obtain a focused history and physical exam and order labs, including an arterial blood gas analysis, or ABG, and CMP. Patients may report diarrhea and vomiting, or they may have a history of diabetes mellitus. The physical exam might reveal signs of dehydration, such as dry oral mucous membranes and decreased skin turgor. And there might be an increased respiratory rate as the body tries to compensate for the acidosis. If the ABG shows an arterial pH below 7.35 and the CMP shows decreased serum bicarbonate, typically below 22 milliequivalents per liter, that's metabolic acidosis. Here's a clinical pearl. In metabolic acidosis, the body tries to compensate by increasing the rate and depth of breathing, which eliminates CO2 and lowers the pCO2. To assess if the compensation is adequate, use the Winter formula. The range of expected pCO2 is equal to 1.5 times the bicarbonate level plus 8 and plus or minus 2. If the measured pCO2 falls within the calculated range, the respiratory compensation is adequate. On the flip side, if the measured pCO2 is higher than calculated, there might be both metabolic and respiratory acidosis occurring at the same time. Lastly, if the measured pCO2 is lower than calculated, your patient might be having concurrent metabolic acidosis and respiratory alkalosis. Now that you know your patient has metabolic acidosis, your next step is to calculate the anion gap. The normal anion gap is due to the difference between unmeasured anions like sulfate, phosphate, albumin, and organic anions and cations such as potassium, magnesium, and calcium. Therefore, fluctuations in these unmeasured anions and cations may influence the anion gap. To calculate, use this formula: serum sodium minus the sum of the serum chloride and bicarbonate. Okay, let's go over a normal anion gap range. A normal anion gap ranges from 4 to 12 milliequivalents per liter. If your patient has a normal anion gap, look for the specific cause. To remember the causes of normal anion gap metabolic acidosis, use the mnemonic HARDUPS. H stands for hyperalimentation, which is the delivery of nutrients into the vein, hypoadrenalism, and hypoaldosteronism. A for acetazolamide, R for renal tubular acidosis, D for diarrhea, U for ureterostomies, P for post-hypocapnic state, and finally, S stands for spironolactone, as well as saline infusion. Okay, first let's go over iatrogenic causes, referring to hyperalimentation, saline infusion, and acetazolamide. In such cases, patients might have a recent history of receiving total parenteral nutrition, or TPN, or infusion of a large volume of IV normal saline. When amino acids in TPN are metabolized, a lot of hydrogen ions are released, which decreases the pH. Next, saline in large amounts can dilute the serum bicarbonate concentration and disrupt the body's acid-base balance due to excess chloride administered relative to sodium. Additionally, they might report taking medications such as carbonic anhydrase inhibitors like acetazolamide or potassium-sparing diuretics like amiloride. If this is the case, your patient's metabolic acidosis is due to iatrogenic causes. Moving on to renal tubular acidosis, which causes metabolic acidosis due to either impairment of hydrogen secretion, like in types 1 and 4, or bicarbonate absorption, like in type 2. These patients often report muscle weakness and possibly a history of recurrent urinary tract infections and kidney stones. Their CMP may show slightly elevated BUN and creatinine. With these findings, consider renal tubular acidosis and calculate the eGFR. Normal eGFR, meaning above 60 milliliters per minute, confirms your diagnosis of renal tubular acidosis. Next up is gastrointestinal loss of bicarbonate through diarrhea. Patients typically report profuse diarrhea, while the physical exam may show signs of dehydration like dry mucous membranes or decreased skin turgor. Additionally, CMP reveals decreased sodium and potassium levels. If you see these findings, the patient's metabolic acidosis is due to gastrointestinal loss of bicarbonate. Let's go over an elevated anion gap range. Let's start with methanol and ethylene glycol toxicity. Alright, let's take a step back to the anion gap and have a look at individuals with an anion gap of more than 12 milliequivalents per liter. In this case, your patient has an elevated anion gap metabolic acidosis. To remember the causes, use the mnemonic GOLD mark. G stands for glycols, O for oxoproline, L for L-lactate, D for D-lactate, M for methanol, A for aspirin, R for renal failure, and lastly, K stands for ketoacidosis. These patients typically present with a history of ingestion of toxic alcohol from household agents like antifreeze or windshield washer fluid. Additionally, they might have a new onset blindness, usually with methanol toxicity, and the physical exam may show altered mental status. With these findings, consider either methanol or ethylene glycol toxicity. To confirm, obtain serum methanol and ethylene glycol levels. If the methanol level is elevated, diagnose methanol toxicity. However, if the ethylene glycol level is elevated, diagnose ethylene glycol toxicity. Here's a high-yield fact. Methanol toxicity triggers metabolic acidosis through its conversion into formic acid, which in turn inhibits mitochondrial function, resulting in the accumulation of lactic acid. An almost similar process occurs with ethylene glycol toxicity. Once converted into its metabolites, glycolic acid and oxalic acid, it causes depression of the central nervous system and renal failure, ultimately resulting in metabolic acidosis. Next up is lactic acidosis. These patients typically have a history of recent shock. The physical exam might reveal signs of poor tissue perfusion, such as low blood pressure, increased heart rate, cool extremities, and prolonged capillary refill time. With these findings, consider lactic acidosis. To confirm, order a serum lactic acid, and if it's elevated, you can diagnose lactic acidosis. Now, isoniazid overdose can inhibit the conversion of lactate to pyruvate in the liver, resulting in lactate accumulation. Patients often present with acute onset of nausea and vomiting and a history of tuberculosis treated with isoniazid. The physical exam may show altered mental status. If you see this, think isoniazid toxicity. Another cause of lactate accumulation is iron toxicity, which can cause mitochondrial dysfunction by interfering with the Krebs cycle, ending up with cellular death and lactate accumulation. These patients typically report excessive iron ingestion, usually in the form of supplements, and may have abdominal pain, vomiting, and fever. In severe cases, there might be hematemesis or hematochezia. The physical exam reveals an elevated body temperature and low blood pressure. With these findings, consider iron toxicity. To confirm, order serum iron level. If it's elevated, diagnose iron toxicity. Here's a high-yield fact. Short bowel syndrome can also cause an accumulation of lactate. Because sugars don't get fully absorbed, gut bacteria convert them to D-lactate, which can accumulate, leading to acidosis. Next up is salicylate toxicity. Patients typically report ingestion of salicylate-containing medications such as aspirin. The physical exam reveals an increased respiratory rate and depth of breathing and low blood pressure. With these findings, consider salicylate toxicity and order serum salicylate level. If it comes back elevated, that's salicylate toxicity. Here's another high-yield fact. Salicylate toxicity can cause both respiratory alkalosis and metabolic acidosis. Salicylates directly stimulate the medulla, which causes hyperventilation and subsequent respiratory alkalosis. As salicylates get metabolized, keto acids and lactic acid build up, leading to metabolic acidosis. When these mechanisms are combined, they can result in a normal arterial pH. Okay, let's consider severe renal disease. These patients typically report decreased urine output, nausea, vomiting, and fatigue. They might also have a known history of kidney disease. The physical exam might reveal elevated blood pressure and peripheral edema. Next, CMP typically reveals elevated BUN, creatinine, and potassium. With these findings, consider renal disease. To confirm, calculate the eGFR. If it is under 30 milliliters per minute, you can diagnose severe renal disease. Here's a clinical pearl. When the eGFR is 30 to 59 milliliters per minute, your patient has moderate renal disease. Unlike severe renal disease, where the kidneys are unable to excrete excessive acid buildup, in moderate renal disease, there is usually adequate acid excretion so the anion gap is maintained within the normal range. Time to move on to ketoacidosis. Patients often report unintentional weight loss, abdominal pain, and vomiting. They may also have a history of diabetes mellitus with poor insulin adherence, prolonged fasting, or excessive alcohol use. The physical exam may reveal signs of dehydration, including dry mucous membranes and decreased skin turgor. There might also be a fruity odor to the breath. Finally, look out for Kussmaul breathing, which is a rapid and deep pattern of breathing, reflecting the body's attempt to compensate for the low arterial pH by expelling excess CO2. With these findings, consider ketoacidosis. To confirm, order labs, including serum ketones and a urinalysis. If serum ketones are elevated and urinalysis reveals ketonuria, you can diagnose ketoacidosis. Alright, as a quick recap, metabolic acidosis refers to increased hydrogen ion concentration with decreased bicarbonate concentration in the blood. The diagnosis is confirmed when the arterial pH is below 7.35 and the bicarbonate level is less than 22 milliequivalents per liter. Causes of normal anion gap metabolic acidosis can be remembered with a mnemonic, HARDUPS. While Goldmark is a good mnemonic to remember the causes of elevated anion gap metabolic acidosis.
Metabolic alkalosis refers to an increase in serum bicarbonate concentration, either due to the loss of hydrogen ions from the body or the gain of bicarbonate itself. This can cause the arterial pH to rise above 7.45 and the serum bicarbonate above 27 milliequivalents per liter. As a reference, bicarbonates normally range from 22 to 27 milliequivalents per liter. Common causes include prolonged vomiting, hypovolemia, diuretic use, and hypokalemia. If a patient presents with a chief concern suggesting metabolic alkalosis, first perform an ABCDE assessment to determine if they are stable or unstable. If your patient is unstable, stabilize their airway, breathing, and circulation. Obtain IV access and put them on continuous vital sign monitoring. Also, provide supplemental oxygen if needed. Here's a clinical pearl. Patients with severe metabolic alkalosis, meaning pH over 7.6, sometimes require urgent correction of blood pH with hemodialysis, especially if there's volume overload or renal dysfunction. Let's move on to stable patients. After the ABCDE assessment, obtain a focused history and physical examination and order labs, including an arterial blood gas analysis or ABG and CMP. The history may reveal vomiting or use of loop or thiazide diuretics. Alkalosis increases the protein binding of ionized calcium, so you might find headaches, lethargy, neuromuscular excitability, delirium, tetany, and seizures. Additionally, alkalemia lowers the threshold for anginal symptoms and arrhythmias. Lastly, if there is hypokalemia, the patient might report weakness. The physical exam might show signs of dehydration, like dry mucous membranes and decreased skin turgor. As for the labs, ABG typically shows an arterial pH above 7.45, while CMP reveals elevated serum bicarbonate, often above 27 milliequivalents per liter. If you see these findings in history, physical exams, and labs, that's metabolic alkalosis. Here's a clinical pearl. Metabolic alkalosis can sometimes coexist with other acid-based disorders, making it hard to identify. To figure this out, you need to check the partial pressure of carbon dioxide, or PCO2, on the ABG. If the PCO2 is above the reference range, it might be due to respiratory compensation, or it could mean that metabolic alkalosis and respiratory acidosis are occurring at the same time. Keep in mind that in chronic metabolic acidosis, PCO2 should increase by about 5 millimeters of mercury for every 10 milliequivalents per liter increase in bicarbonates. On the other hand, if the PCO2 is below reference range, metabolic alkalosis might be associated with a coexisting respiratory alkalosis. Now that you've diagnosed metabolic alkalosis, let's assess for exogenous causes. First up is milk alkali syndrome. Milk alkali is characterized by hypercalcemia, renal insufficiency, and metabolic alkalosis. Hypercalcemia often results from ingestion of excessive amounts of calcium, either as supplements or calcium-based antacids. If it's not addressed, hypercalcemia can cause renal insufficiency, where the kidney's ability to excrete bicarbonate is impaired. Consequently, serum bicarbonate levels increase, leading to metabolic alkalosis. Patients usually have a history of excessive calcium supplementation or the use of absorbable antacids like calcium carbonate or sodium bicarbonate. The CMP often shows elevated serum calcium, BUN, and creatinine levels. If you see these findings, diagnose milk alkali syndrome. Next, there's bicarbonate administration. These patients present with a recent history of large volume alkaline fluid infusion, such as IV sodium bicarbonate, usually to treat acidosis. In this case, bicarbonate administration is the cause of metabolic alkalosis. Here's another clinical pearl. In individuals with normal kidney function, the ingestion or administration of alkali results in only transient metabolic alkalosis. Normally functioning kidneys will quickly increase bicarbonate excretion to restore the pH balance. However, in individuals with kidney dysfunction, the effective elimination of excess bicarbonate is compromised, which leads to sustained alkalosis. Now for endogenous causes. Alright, if there are no exogenous causes of metabolic alkalosis, consider endogenous causes and obtain a spot urine chloride test. If the urine chloride is 20 milliequivalents per liter or less, it means there is significant renal chloride reabsorption, so your patient has chloride-responsive metabolic alkalosis. This is often found in conditions such as gastric alkalosis, cystic fibrosis, and laxative abuse. let's go over chloride-responsive metabolic alkalosis. Let's start with gastric alkalosis, also known as contraction alkalosis. During vomiting or nasogastric suction, hydrogen chloride is lost in the form of gastric acid, so less acid reaches the duodenum where hydrogen chloride is necessary to counterbalance the pancreatic and duodenal secretions of bicarbonates. With insufficient acid, an excess of bicarbonate gets absorbed into the bloodstream, contributing to metabolic alkalosis. Patients with gastric alkalosis typically present with a history of vomiting or prolonged nasogastric suction. The physical exam might reveal signs of hypovolemia, such as increased heart rate, decreased blood pressure, decreased skin turgor, and dry mucous membranes. With these findings, diagnose gastric alkalosis. Next up is cystic fibrosis, in which excessive amounts of sodium chloride in water are lost through sweat, leading to extracellular volume contraction. This activates the renin-angiotensin-aldosterone system, or RAS, which is followed by a rise in angiotensin II and aldosterone levels. Increased aldosterone levels cause the kidneys to secrete more potassium and hydrogen ions while reabsorbing more bicarbonate, which eventually results in metabolic alkalosis. The patient typically reports a history of recurrent respiratory infections, poor weight gain, and fatty stool, called steatorrhea. The physical exam usually reveals digital clubbing and lung crackles or wheezing. With these findings, consider cystic fibrosis. Next, order a sweat chloride test, and if it's elevated, diagnose cystic fibrosis. Okay, time to talk about laxative abuse. History might reveal the use of laxative medications and possibly an eating disorder like bulimia nervosa. Since some patients might not be comfortable reporting this in their history, during physical exam, look for signs of self-induced vomiting, such as tooth decay and abrasions on the dorsum of the hands or fingers. CMP usually reveals decreased serum potassium levels. If you see these findings, think laxative abuse. Alright, let's go back to the urine chloride and discuss situations where it exceeds 20 milliequivalents per liter. In this case, diagnose chloride-resistant metabolic alkalosis. Your next step is to assess the patient's blood pressure to narrow down potential causes. If your patient is normotensive and has recently begun taking loop or thiazide diuretics, their chloride-resistant metabolic alkalosis is due to acute diuretic use. Here are some high-yield facts. Laxative abuse causes a loss of potassium through the stool, which ultimately leads to hypokalemia. At the cellular level, hypokalemia triggers an exit of potassium ions out of the cells and an entry of hydrogen ions into the cells. This reduces the overall hydrogen ion concentration relative to the bicarbonate level in the blood, eventually resulting in metabolic alkalosis. However, if laxative abuse induces severe diarrhea over an extended period, there will be an excessive loss of bicarbonate ions as well, morphing into metabolic acidosis. Now, loop and thiazide diuretics work similarly by increasing urine loss of potassium and hydrogen ions relative to the serum bicarbonate level, resulting in metabolic alkalosis. That's why urinary potassium can help you differentiate between the two. If it's less than 30 milliequivalents per day, you are dealing with hypokalemia or laxative abuse. On the flip side, if it's more than 30 milliequivalents per day in a patient without hypertension, that's probably diuretic abuse or Bartter or Gettleman syndrome. And here's a clinical pearl. Loop and thiazide diuretics cause chloride-resistant metabolic alkalosis only when they are taken acutely. If either drug is taken chronically, the urine chloride will eventually drop between doses, resulting in chloride-responsive metabolic alkalosis. Alright, let's move on to Bartter and Gettleman syndromes, which are both autosomal recessive conditions associated with defective reabsorption of sodium ions, chloride ions, and water by the kidneys. This leads to a decrease in the extracellular fluid volume, activating RAS. The result will be the loss of potassium and hydrogen ions and the reabsorption of more bicarbonate ions, ending up in metabolic alkalosis. These patients present with polyuria and polydipsia, abdominal cramps, and possibly muscle weakness. There might be a personal or familial history of chronic diarrhea. On CMP, there is decreased serum potassium. With these findings, consider genetic conditions like Bartter or Gettleman syndrome. To distinguish between the two, order genetic testing. If the results show SLC12A1 gene mutation, diagnose Bartter syndrome. On the other hand, if genetic testing reveals SLC12A3 gene mutation, that's Gettleman syndrome. Here's a clinical pearl. Children with Bartter syndrome typically have increased urinary calcium excretion with normal serum magnesium, while those with Gettleman syndrome usually have low urinary calcium excretion and low serum magnesium. Now, let's shift our focus to hypertensive patients. Here, your next step is to check plasma renin activity. If plasma renin activity is high, consider a renin-secreting tumor. To confirm, order an abdominal ultrasound or a CT. If it shows a renal tumor, you have your diagnosis of a renin-secreting tumor. On the other hand, if there's no renal tumor, consider renal artery stenosis. In this condition, compromised blood flow to the kidneys can activate RAS, causing the rise of angiotensin II and aldosterone levels. Aldosterone stimulates the secretion of more potassium and hydrogen ions while enhancing the reabsorption of bicarbonate, which eventually leads to metabolic alkalosis. To confirm the diagnosis, order a color Doppler ultrasound. If it detects turbulent blood flow in the renal artery, diagnose renal artery stenosis. Now, if plasma renin activity is low, you should check your patient's plasma aldosterone level. If it is also low, consider Cushing syndrome as your diagnosis. To confirm, get a late-night salivary cortisol, a 24-hour urinary-free cortisol level, or a low-dose overnight dexamethasone suppression test. The cortisol level above the reference range confirms the diagnosis of Cushing syndrome. Here's a high-yield fact. In Cushing syndrome, the excess cortisol can mimic the effect of aldosterone by binding to the kidney's mineralocorticoid receptors. This will result in hypokalemia, which eventually leads to metabolic alkalosis. Finally, if the plasma aldosterone level is high, consider hyperaldosteronism as the cause of metabolic alkalosis. Next, obtain an abdominal CT scan, and if it shows an adrenal mass, diagnose primary hyperaldosteronism as the cause of metabolic alkalosis. All right, as a quick recap, metabolic alkalosis refers to an increase in serum bicarbonate concentration, either due to the loss of hydrogen ions from the body or the gain of bicarbonate itself. The diagnosis is confirmed when the arterial pH exceeds 7.45 and bicarbonates are above 27 milliequivalents per liter. Causes of metabolic alkalosis can be exogenous or endogenous, which can be further divided into chloride-responsive and chloride-resistant metabolic alkalosis.
Respiratory acidosis refers to an increase in partial pressure of carbon dioxide, or PCO2, with or without a compensatory increase in bicarbonate, resulting in increased hydrogen ion concentration in the blood. This is almost always caused by hypoventilation, usually from the central nervous system, pulmonary, or iatrogenic conditions. Generally, respiratory acidosis is characterized by an arterial pH below 7.35 and a PCO2 above 45 millimeters of mercury. As a reference, the normal PCO2 range is between 35 and 45 millimeters of mercury. If a patient presents with a chief concern suggesting respiratory acidosis, first perform an ABCDE assessment to determine if your patient is stable or unstable. If your patient is unstable, stabilize their airway, breathing, and circulation. Next, obtain IV access and put your patient on continuous vital sign monitoring. Finally, provide supplemental oxygen if needed. Here's a clinical pearl. Respiratory acidosis can be acute or chronic. The chronic form is asymptomatic. However, if it worsens or if the patient has an acute case, they might present with headache, confusion, and altered mental status. Their exam might show tremors, myoclonic jerks, and asterixis. These patients may require adequate ventilation by either endotracheal intubation or non-invasive positive pressure ventilation. Now that unstable patients are taken care of, let's talk about stable ones. Your next step here is to obtain a focused history and physical examination and order labs, including an arterial blood gas analysis, or ABG, and BMP. History findings depend on the specific cause, but most patients have shortness of breath. The physical exam might show abnormal breathing patterns, such as a decreased respiratory rate, and signs of hypoxemia, like cyanosis. As for the labs, ABG typically reveals an arterial pH below 7.35 and a PCO2 above 45 millimeters of mercury. BMP usually reveals normal or increased serum bicarbonate, depending on whether there is metabolic compensation, and possibly electrolyte imbalances, such as increased serum potassium. If you see these findings, that's respiratory acidosis. Here's a clinical pearl to keep in mind. After diagnosing respiratory acidosis, remember to assess for metabolic compensation by checking the serum bicarbonate level. A compensated respiratory acidosis is characterized by a normal or slightly decreased arterial pH, increased PCO2, and increased serum bicarbonate level. This occurs in chronic conditions where the kidneys have been able to reabsorb enough bicarbonate, restoring the acid-base balance. Examples include interstitial lung diseases, restrictive chest wall disorders, and obesity. On the other hand, uncompensated respiratory acidosis will have a decreased arterial pH, increased PCO2, and normal serum bicarbonate level. A simple way to know if there is metabolic compensation in respiratory acidosis and alkalosis is to use the 1-2-3-4-5 rule. In the case of acidosis, for every 10 millimeters of mercury rise of PCO2 from the baseline of 40 millimeters of mercury, bicarbonates, or HCO3, should increase by 1 in the acute or by 4 in the chronic respiratory acidosis from their baseline of 24 millimoles per liter. When it comes to alkalosis, for every 10 millimeters of mercury decrease of PCO2 from the baseline, bicarbonate should decrease by 2 for the acute or 5 for the chronic respiratory alkalosis from the baseline. Alright, let's talk about underlying causes, starting with iatrogenic ones. This is usually seen with hospitalized patients on respiratory support such as mechanical ventilation, so you'll need to check the ventilator settings. If either the respiratory rate or tidal volume is too low, or if there's any evidence of equipment failure, your patient might not be exhaling enough carbon dioxide. In this case, diagnose iatrogenic hypoventilation. Here's another clinical pearl. Other major causes of iatrogenic respiratory acidosis include medications that primarily work by depressing the CNS activity. Examples include anesthetic agents like propofol, sedatives like benzodiazepines, and opioids such as morphine. Let's move on to the central nervous system, or CNS-related causes. These can lead to a decrease in the activity of the respiratory centers in the brainstem. Examples include intracranial pathologies such as brainstem stroke or trauma, substance abuse, and alcohol intoxication. First up are intracranial pathologies. The history might reveal an acute onset of headache and risk factors for stroke such as high blood pressure, smoking, or atrial fibrillation. Also, don't forget to ask about any recent head trauma. The physical exam reveals a decreased respiratory rate and possibly altered mental status or focal neurological deficits like slurred speech. With these findings, consider intracranial pathology and order a head CT scan or MRI. If imaging reveals ischemic changes or hemorrhage, your patient's respiratory acidosis is due to an intracranial pathology. Next up is substance use or alcohol intoxication. In this case, history reveals the use of CNS depressants such as alcohol or opioids like morphine and heroin. On a physical exam, you'll find a decreased respiratory rate and sometimes altered mental status. Be sure to check for pupil changes, particularly miosis, which would suggest opioid use. With these findings, consider substance use or alcohol intoxication and obtain a urine toxicology screen and serum alcohol level. If the urine toxicology is positive for a relevant substance, diagnose substance use. On the other hand, if the serum alcohol level is elevated, then alcohol intoxication is the cause of respiratory acidosis. Alright, let's move on to the causes related to airway obstruction. The key ones you should remember include severe asthma exacerbation and foreign body aspiration. Patients with severe asthma exacerbation typically present with a cough with or without chest tightness and a known history of asthma. The physical exam reveals bilateral wheezing with a rapid, shallow breathing pattern. In this case, consider severe asthma exacerbation. Next, administer a bronchodilator. If there is clinical improvement, meaning improved breathing pattern and decreased wheezing, your patient's respiratory acidosis is due to asthma exacerbation. Next up is foreign body aspiration. In these cases, history reveals choking and coughing with known or suspected foreign body aspiration. The physical exam might reveal stridor, wheezing, or decreased breath sounds. With these findings, consider foreign body aspiration. Then order a chest X-ray, and if a foreign body is identified, you can diagnose foreign body aspiration. Here's a clinical pearl. Other forms of airway obstruction that can lead to respiratory acidosis include lung tumors and mucus plugging. A patient with a lung tumor will likely have a history of weight loss, hemoptysis, and usually a smoking history. On the other hand, patients with mucus plugging typically report recurrent respiratory infections and may have COPD or cystic fibrosis. In both cases, you will need a chest CT scan to confirm the diagnosis, which might show a tumor or filling defects within the bronchi in the case of mucus plugging. Okay, let's talk about diseases affecting the lung parenchyma. Patients with pneumonia usually report productive cough, while the physical exam might reveal elevated body temperature, decreased oxygen saturation, and lung crackles. With these findings, consider pneumonia and order a chest X-ray. If it reveals infiltrates, you can go ahead and diagnose pneumonia as the cause of respiratory acidosis. Next up is ARDS. History typically reveals an acute onset of shortness of breath, often triggered by inhalation injury, pneumonia, or pancreatitis. The physical exam might reveal accessory respiratory muscle use, decreased oxygen saturation, and diffuse lung crackles. With these findings, consider ARDS. To confirm, order a chest X-ray and calculate the ratio of partial pressure of oxygen, or PaO2, to the estimated fraction of inspired oxygen, or FiO2. If chest X-ray shows bilateral infiltrates and the PaO2 to FiO2 ratio is 300 millimeters of mercury or less, you can diagnose ARDS. Lastly, let's have a look at the neuromuscular causes of respiratory acidosis. These patients usually have a known history of neuromuscular diseases such as myasthenia gravis, Guillain-Barré syndrome, or muscular dystrophy. These diseases can cause weakness of the diaphragm and accessory respiratory muscles, leading to inefficient respiration and subsequent respiratory acidosis. So along with neuromuscular disease, symptoms vary based on the condition and can include muscle weakness or ineffective coughing. The physical exam might show dysarthria, symmetrical limb weakness, ascending paralysis, and ptosis. In this case, your patient's respiratory acidosis is due to a neuromuscular disease. Alright, as a quick recap, respiratory acidosis is confirmed when the arterial pH is below 7.35 and the PCO2 is above 45 millimeters of mercury. Causes of respiratory acidosis can be classified into several categories. There are iatrogenic causes such as inappropriate mechanical ventilator settings, CNS-related conditions including intracranial pathology or substance use, airway obstruction like in severe asthma exacerbation or foreign body aspiration, lung parenchyma-related causes such as pneumonia and ARDS, and finally, neuromuscular causes which include conditions like myasthenia gravis.
Respiratory alkalosis refers to a decrease in the partial pressure of carbon dioxide, or PCO2, resulting in a decrease in the concentration of hydrogen ions in the blood. This is almost always caused by hyperventilation, which increases carbon dioxide removal relative to carbon dioxide production. Hyperventilation typically occurs in response to triggers such as hypoxia, infection, metabolic acidosis, pain, anxiety, overdose of certain medications, or increased metabolic demand. Respiratory alkalosis is characterized by a pH above 7.45 and a PCO2 below 35 millimeters of mercury. As a reference, the normal PCO2 range is between 35 and 45 millimeters of mercury. If a patient presents with a chief concern suggesting respiratory alkalosis, perform an ABCDE assessment to determine if your patient is stable or unstable. If they are unstable, stabilize the airway, breathing, and circulation. Next, obtain IV access and put your patient on continuous vital sign monitoring. Lastly, provide supplemental oxygen if needed. Let's jump back to the ABCDE assessment and talk about stable patients. Your next step here is to obtain a focused history and physical examination and order labs, including an arterial blood gas analysis, or ABG, and BMP. The history will vary depending on the specific cause, but your patient may report shortness of breath, while the physical exam might show an increased rate and depth of breathing. ABG typically shows an arterial pH above 7.45 and a PCO2 lower than 35 millimeters of mercury. Finally, BMP will show normal or decreased serum bicarbonate, depending on whether or not there is metabolic compensation, and might show electrolyte imbalances such as hypokalemia. With these findings, you can diagnose respiratory alkalosis. Here are some clinical pearls. Once you've diagnosed respiratory alkalosis, remember to assess for metabolic compensation by checking the serum bicarbonate level. A compensated respiratory alkalosis is characterized by a normal or slightly increased arterial pH, decreased PCO2, and decreased serum bicarbonate level. This can be seen in chronic conditions in which the kidneys have had time to restore the acid-base balance by excreting excess bicarbonate. Examples include pregnancy, hyperthyroidism, and chronic liver disease. On the other hand, uncompensated respiratory alkalosis will have an increased arterial pH, a decreased PCO2, and a normal serum bicarbonate level. A simple way to know if there is metabolic compensation in respiratory alkalosis and acidosis is to use the 1-2-3-4-5 rule. When it comes to acidosis, for every 10 millimeters of mercury rise of PCO2 from the baseline, bicarbonates should increase by 1 in the acute or by 4 in the chronic respiratory acidosis from their baseline. On the flip side, in alkalosis, bicarbonate or HCO3 should decrease by 2 for the acute or 5 for the chronic respiratory alkalosis from the baseline of 24 millimoles per liter. Alright, let's go over causes of respiratory alkalosis, starting with iatrogenic ones. This is often seen in hospitalized patients on respiratory support, like mechanical ventilation. In this case, you should check the ventilator settings. If the respiratory rate or the tidal volume is too high, your patient might be removing excessive amounts of carbon dioxide, resulting in a low PCO2 and eventually alkalosis. At this point, you can diagnose iatrogenic hyperventilation. Next, let's take a look at the CNS-related causes. These are conditions that mainly lead to stimulation of the respiratory centers in the brainstem, leading to hyperventilation, then a low PCO2, and ultimately respiratory alkalosis. First up is psychogenic hyperventilation. These patients typically present with a sudden onset of shortness of breath and fear, often associated with an anxiety disorder. The physical exam reveals an increased rate and depth of breathing, but with no other signs of acute illness. If you see these findings, that's psychogenic hyperventilation. Next up are CNS infections. In this case, history reveals fever, headache, photophobia, and with or without neck stiffness, while the physical exam shows altered mental status and possibly nuchal rigidity. If you see this, consider a CNS infection. This could be like meningitis or encephalitis. Next, perform a lumbar puncture to collect cerebrospinal fluid and send it for analysis. If it shows any abnormalities, then the patient's respiratory alkalosis is due to a CNS infection. Moving on to intracranial pathologies. Sometimes your patient might report a headache, a recent history of head trauma, or seizures. The physical exam might reveal altered mental status, anisocoria, which refers to asymmetric pupils, and focal neurological deficits such as hemiplegia. With these findings, you should suspect an intracranial pathology, and then obtain a brain CT scan to confirm. If the CT reveals an intracranial tumor, diagnose your patient with respiratory alkalosis due to an intracranial tumor. On the other hand, if the CT scan shows hemorrhage, diagnose respiratory alkalosis due to intracranial hemorrhage. Alright, let's have a look at the pulmonary causes of respiratory alkalosis. These conditions cause hypoxemia, which triggers hyperventilation and eventually leads to a decreased PCO2. Let's start with pulmonary embolism. In this case, the history typically reveals an acute onset of pleuritic chest pain, shortness of breath, and sometimes hemoptysis. The physical exam might reveal an increased respiratory rate, a low-grade fever, and/or unilateral calf pain and swelling. With these findings, consider pulmonary embolism and obtain a CT angiogram of the chest. If it shows filling defects of pulmonary vessels, that's pulmonary embolism. Moving on to pneumothorax. These patients present with an acute onset of chest pain and sometimes a recent history of chest trauma, although pneumothorax can result from ruptured blebs as well. Some might have a history of chronic obstructive pulmonary disease or pulmonary fibrosis. The physical exam might show low blood pressure, jugular venous distension, and resonance on chest percussion. In more severe cases, you can notice tracheal deviation. With these findings, consider pneumothorax and order a chest X-ray for confirmation. If the X-ray shows a visible, visceral pleural edge with no peripheral lung markings, you can diagnose respiratory alkalosis due to pneumothorax. Next up is hemothorax. Your patient will typically report acute chest pain with a history of chest trauma and possibly a pre-existing coagulation disorder such as hemophilia. The physical exam might reveal dullness on chest percussion and decreased tactile fremitus. In this case, consider hemothorax and obtain a chest ultrasound. If it shows a homogeneous and echogenic effusion, that's hemothorax. Next up are hematological causes of respiratory alkalosis, which mainly involve severe anemia. The history will reveal palpitations and possibly acute blood loss. If the physical exam reveals conjunctival pallor, consider anemia and then obtain a CBC. If there is a significant drop in hemoglobin from the patient's baseline, their respiratory alkalosis is due to severe anemia. Finally, let's talk about drug toxicity and substance abuse. These are mainly CNS stimulants that lead to hyperventilation by activating the respiratory centers in the brainstem. Patients typically present with a history of changes in their medications or are taking salicylate-containing medications, most commonly aspirin. They might also have a history of substance use with stimulant effects on the brain, such as amphetamines and cocaine. The physical exam might show altered mental status, needle marks, or nasal septal damage. With these findings, consider drug toxicity or substance abuse. Next, order a serum salicylate level and a urine toxicology screen. If the toxicology screen is positive for a substance that causes CNS stimulation, diagnose substance use as the cause of respiratory alkalosis. On the flip side, if the serum salicylate level is elevated, you can make the diagnosis of salicylate toxicity. Here's a high-yield fact. Salicylate toxicity can cause both metabolic acidosis and respiratory alkalosis. Salicylates directly stimulate the medulla, which causes hyperventilation and subsequent respiratory alkalosis. As salicylates get metabolized, keto acids and lactic acid build up, leading to metabolic acidosis. When these mechanisms are combined, they can result in a normal arterial pH. Alright, as a quick recap, respiratory alkalosis refers to a decrease in PCO2 and hydrogen ion concentration in the blood. It is confirmed once the blood pH is above 7.45 and PCO2 below 35 millimeters of mercury. Common causes of respiratory alkalosis include iatrogenic causes, such as inappropriate mechanical ventilator settings, CNS causes like psychogenic hyperventilation, infections, and intracranial pathologies, pulmonary causes like pulmonary embolism, pneumothorax, and hemothorax, hematological causes such as severe anemia, and drug toxicity and substance abuse, such as salicylate toxicity and use of amphetamines.
Pneumothorax refers to an abnormal presence of air within the pleural space that can result in a deflated or collapsed lung. The pleural space has a parietal layer, which lines the chest wall, and a visceral layer which lines the parenchyma of the lung. Disruption of either of the pleural layers can allow air to enter the pleural space. This can occur spontaneously, usually due to rupture of anatomic lung defects called blebs and bulli, or traumatic, which might occur after a penetrating chest injury or even a medical procedure. Based on the underlying cause, pneumothorax can be classified as spontaneous pneumothorax, which is further subdivided into primary and secondary spontaneous pneumothorax, and non-spontaneous pneumothorax. Now, if you suspect pneumothorax, you should first perform an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, stabilize the airway, breathing, and circulation. This means that you'll need to assess the need for ventilatory support, and you might need to intubate the patient. Next, obtain IV access. Provide supplemental oxygen to maintain SaO2 above 92%, and put your patient on continuous vital sign monitoring such as pulse oximetry, blood pressure, and heart rate. Next, perform a focused history and physical and get a chest x-ray as soon as possible. Your patient might report sudden chest pain and shortness of breath, while your exam will reveal an asymmetric chest and tracheal deviation away from the affected side, as well as hypotension, respiratory distress, and decreased or absent breath sounds on the affected side. Keep in mind that tension pneumothorax is a clinical diagnosis and doesn't need further testing. However, if you were to perform a chest x-ray, it would show a distinct visceral pleural edge with an absence of lung markings distally, often with a depressed hemidiaphragm ipsilateral to the collapsed lung, known as a deep sulcus sign. In severe cases, you'd see shifting of the mediastinum contralateral to the collapsed lung. Okay, listen up. Here is a clinical pearl. Since tension pneumothorax is so dangerous, it should be diagnosed based on clinical suspicion, and treatment should not be delayed, even if imaging has not been performed or results are not yet available. In fact, you'll want to perform immediate decompression with needle thoracostomy. Identify the second intercostal space where it intersects with the midclavicular line. Then insert an angiocatheter through the chest wall just above the rib. If effective, you will release the trapped air, allowing the lung to reinflate and relieve any mediastinal compression. You will later need to proceed with tube thoracostomy or placement of a chest tube connected to continuous low-pressure suction to allow full reinflation and decrease chances of recurrence. Now, let's jump back to the ABCDE assessment and take a look at stable patients. If your patient is stable, proceed with a focused history and physical examination. Your patient is likely to report sudden onset of pleuritic chest pain, or pain that gets worse with deep breathing, as well as shortness of breath. Common examination findings include tachypnea, shallow breathing, and decreased or absent breath sounds on the affected side of the chest. If these findings are present, suspect pneumothorax and order a chest x-ray. Look for a visceral pleural edge, absence of lung markings, and a deep sulcus sign, while keeping in mind a mediastinal shift is less likely to be present in a stable patient. At this point, you can be sure that the diagnosis is pneumothorax. On the other hand, if you notice findings that are inconsistent with pneumothorax, you should consider an alternative diagnosis. Now that you've diagnosed pneumothorax, the next step is to assess the underlying cause. Ask about a history of trauma to the chest wall and any recent medical procedures where inadvertent trauma may have occurred. If neither of these is present, then the pneumothorax is said to be spontaneous. If spontaneous pneumothorax occurs in the absence of trauma or known lung condition, the pneumothorax is said to be primary. Risk factors for primary spontaneous pneumothorax include young age, tall height, thin body habitus, and being a biologically male individual. Now, the first step in management of a patient with primary spontaneous pneumothorax is to assess the size of the pneumothorax. If it's small, meaning the chest x-ray reveals less than 2 centimeters between the lung edge and chest wall, next you should assess for symptom severity. As long as no symptoms are present, it may often resorb spontaneously, so you can observe your patient. However, if symptoms are present, then you'll need to perform simple needle aspiration or placement of a chest tube. On the other hand, if the pneumothorax is large, in other words, there's 2 centimeters or more in depth, then you will place a chest tube and attach it to continuous suction. Next, order a follow-up chest x-ray to evaluate the lung expansion. If there's full lung expansion, stop the suction and observe your patient for an additional 24 hours. But if the x-ray reveals no lung expansion, make sure to consult the surgical team. Now that we're done with primary spontaneous pneumothorax, let's go all the way back up to the assessment of the underlying cause. Next up are individuals that have no history of trauma, but have an underlying lung condition, such as COPD or pulmonary fibrosis. In this case, the pneumothorax is classified as a secondary spontaneous pneumothorax. Here, you will place a chest tube regardless of symptoms or the size of the pneumothorax and attach the tube to continuous suction, again followed by a repeat chest x-ray to evaluate lung expansion. Just like mentioned previously, if there's full lung expansion, stop the suction and observe your patient for an additional 24 hours, but if the x-ray reveals no lung expansion, then you consult the surgical team. Finally, let's go back to the assessment of the underlying cause. And we'll take a look at patients that present with a history of trauma, such as blunt or penetrating trauma, or a history of medical intervention, such as central line placement, lung biopsy, and mechanical ventilation. In this case, you should think of non-spontaneous pneumothorax, so your next step is to assess the chest wall for penetrating injury. If there's no chest wall defect, non-spontaneous pneumothorax is classified as a closed pneumothorax. So, your next step is to assess the pneumothorax size and treat it just like you would treat the primary spontaneous pneumothorax. On the other hand, if there is a chest wall defect, then your diagnosis is open pneumothorax. So make sure to consult the surgery team, because the chest wall may need surgical repair to allow for proper lung reinflation. Now, here's another high-yield fact. If pneumothorax occurs as a result of a medical intervention, it's called iatrogenic pneumothorax. The most common cause is an inadvertent puncture of the pleura during insertion of a central venous catheter. However, it's also known to occur during needle-based transthoracic procedures like liver biopsy and thoracentesis. They can even occur from mechanical ventilation, usually due to high expiratory pressure settings causing barotrauma. Alright, as a quick recap. If you suspect pneumothorax, perform an ABCDE assessment to determine if your patient is unstable or stable. Unstable individuals typically present with tension pneumothorax and usually require immediate decompression with needle thoracostomy prior to placement of a chest tube. On the other hand, in stable individuals, use a chest X-ray to make the diagnosis. Next, review the patient's history to determine the underlying cause and type of pneumothorax. The initial step in the management of primary spontaneous pneumothorax is determine the pneumothorax size. If it's small, observe the patient as long as no symptoms are present. However, if symptoms are present, treat the pneumothorax either with simple needle aspiration or the placement of a chest tube. On the other hand, if the pneumothorax is large, place a chest tube with continuous suction. Next, order a follow-up chest X-ray to evaluate lung expansion. If the X-ray reveals full lung expansion, stop suction and observe the patient for 24 hours. But if there's no lung expansion, consult the surgical team. On the other hand, in secondary spontaneous pneumothorax, place a chest tube regardless of the size of the pneumothorax, attach the tube to continuous suction, and again order a follow-up chest X-ray to evaluate lung expansion. Finally, in non-spontaneous pneumothorax, assess the chest wall for penetrating injury. If there's no chest wall defect, the diagnosis is closed pneumothorax. So your next step is to determine the pneumothorax size and treat it just like you would treat the primary spontaneous pneumothorax. On the flip side, if you notice any chest wall defects, the diagnosis is open pneumothorax. So immediately consult the surgical team.
Anxiety disorders are conditions characterized by excessive fear and anxiety. Fear is an emotional reaction to a threat, either real or perceived, and is usually associated with autonomic arousal. Anxiety, on the other hand, is the anticipation of a future threat. It's not usually associated with autonomic arousal, and it often causes maladaptive changes in thinking or behavior. Distinguishing between the various anxiety disorders requires identifying the triggers that set them off, any related changes in thinking or behavior, and assessing the Diagnostic and Statistical Manual, or the DSM-5 criteria. Common anxiety disorders include panic disorder with or without agoraphobia, obsessive-compulsive disorder, or OCD, specific phobias, social anxiety disorder, and generalized anxiety disorder, or GAD. When a patient presents with a chief concern suggesting an anxiety disorder, first perform a focused history and physical examination. Your patient will report excessive fear or anxiety, or sometimes both. In some cases, they might also report chest discomfort. The physical exam might show restlessness, a tense or constricted affect, tachycardia, or elevated blood pressure. With these findings, consider an anxiety disorder and investigate further to determine the specific type. Let's start by assessing for a history of panic attacks. A panic attack is an abrupt period of intense fear, accompanied by an uncomfortable surge of autonomic arousal, where the heart beats faster, respirations increase, and muscles tense up. Patients might report trembling, sweating, chest discomfort, palpitations, shortness of breath, nausea, paresthesias, or lightheadedness. Additionally, there might be associated emotional symptoms like crying, dissociation, feeling out of control, or fear of dying. Panic attacks can be triggered by stressful situations or can occur unexpectedly. Here's an important clinical pearl. An acute panic attack can present like acute coronary syndrome, with symptoms such as diaphoresis, chest discomfort, and shortness of breath. With this presentation, be sure to evaluate for cardiac causes. This is especially recommended if it's a patient's first episode or if there are any risk factors for cardiovascular disease. In this case, order cardiac enzymes and a 12-lead ECG. If it's a true panic attack, cardiac enzymes will be unremarkable and the ECG will show no signs of ischemia. Now, if your patient experiences recurrent panic attacks, consider panic disorder. To confirm the diagnosis, assess the DSM-5 criteria, which specify that they must have repeated, unexpected panic attacks. Also, they must experience at least 1 month of nearly constant worry about future episodes, or make maladaptive changes to their behavior to avoid having attacks, or both. If these criteria are met and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose panic disorder. Here's a clinical pearl to keep in mind. Certain medical conditions can cause symptoms resembling panic attacks. These include hyperthyroidism, hyperparathyroidism, seizures, and pheochromocytoma. Additionally, certain medications such as steroids, stimulants, and similar drugs of abuse can trigger these symptoms. So keep an eye out for these possibilities during your assessment. Okay, once you've diagnosed panic disorder, your next step is to determine if agoraphobia is present. Agoraphobia refers to fear or anxiety about situations, such as using public transportation, being in open spaces like a parking lot, being in enclosed spaces like a theater, standing in line or being in a crowd, or being alone outside of their home. Your patient will report avoiding situations like these or endure them with extreme anxiety due to fear that they'll be unable to escape or that there's no help available if something terrible happens, like visibly panicking or becoming embarrassed. The amount of anxiety they experience will be out of proportion to the actual danger these situations pose to them, and it will impair their ability to function in important areas of life, like social or occupational contexts. If agoraphobia has been persistent for at least 6 months and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose panic disorder with agoraphobia. Otherwise, diagnose panic disorder without agoraphobia. Here's another clinical pearl to keep in mind. Agoraphobia is typically diagnosed in association with panic disorder, but it can occur independently. For instance, an elderly person may develop agoraphobia associated with the fear of falling or having incontinence outside the home, but without associated episodes of panic. In this case, agoraphobia can result in problems like missing important medical appointments or becoming socially reclusive. Now, let's look at when your patient reports infrequent or no panic attacks. In this case, your next step is to assess for the presence of obsessions and compulsions. Obsessions are recurrent, intrusive thoughts that can manifest as images or urges that cause significant anxiety or distress. On the other hand, compulsions are ritualized attempts aimed at alleviating the anxiety caused by obsessions. The content or subject of obsessions and compulsions can vary from patient to patient, and common themes include contamination, symmetry, or danger. And here's another clinical pearl. Compulsions can manifest as either mental or behavioral acts, often unrelated to the obsession in a realistic manner. Examples of compulsions include excessive hand-washing, arranging or ordering items, counting, repeating words or phrases, or repeatedly checking locks. Now, if obsessions or compulsions are present, consider obsessive compulsive disorder, or OCD for short. Next, assess whether your patient meets the DSM-5 criteria for OCD. In addition to obsessions, compulsion, or both being present, the symptoms must take up a significant amount of time, impair their ability to function, or cause significant distress. If these criteria are met, and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose OCD. Now, let's discuss patients with no obsessions or compulsions. In this case, your next step is to assess for other specific triggers causing your patient's anxiety. If your patient describes a single, specific situation or object that provokes immediate fear or anxiety, consider specific phobia and assess the DSM-5 criteria. Here, the fear or anxiety persists for at least 6 months, and it must be out of proportion to the actual danger posed by the situation or object. Also, they'll either actively avoid the situation or object, or endure it with intense anxiety. Finally, the fear or anxiety must cause significant distress or impair their ability to function. If these criteria are met, and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose specific phobia. Here's another clinical pearl to keep in mind. It's quite common for an individual to have more than one specific phobia, which would be separate comorbid diagnoses. There are 4 main categories of triggers: animals like spiders or dogs, natural environments like heights or storms, situations like elevators or airplanes, or blood injection injury events like medical procedures and needles. Additionally, there are other miscellaneous phobias, such as fear of vomiting or fear of loud sounds. Okay, now let's look at when your patient's anxiety is triggered by social situations. In this case, you should consider social anxiety disorder. This form of anxiety is generally due to excessive fear or anxiety about social situations where they might be embarrassed or judged by others. To confirm the diagnosis, assess the DSM-5 criteria. The fear or anxiety must persist for at least 6 months, and it must be out of proportion to the actual threat posed by the situation. Also, they'll either actively avoid the social situation or endure it with intense anxiety. Finally, the fear and anxiety must cause significant distress or impair their ability to function. If these criteria are met, and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose social anxiety disorder. Here's another clinical pearl. Social anxiety can present in lots of ways, depending on the patient. Some patients avoid eating in public or using public restrooms to avoid potentially embarrassing situations. Others clam up at work due to fear of being judged as weak, offensive, or unlikable. Additionally, performance anxiety is a subtype of social anxiety and includes fear of public speaking or stage fright. Finally, let's have a look at when your patient has excessive anxiety and worry about routine situations such as finances, relationships, work or school performance, or health. With this presentation, you should consider generalized anxiety disorder, or GAD for short, and assess the DSM-5 criteria. To meet the criteria, your patient's anxiety and worry must be present more days than not for at least 6 months, and be associated with 3 or more of the following physical symptoms: restlessness, fatigue, poor concentration, irritability, muscle tension, or poor sleep. In addition, the anxiety and worry are difficult to control, cause significant distress, or impair their ability to function. If these criteria are met, and there's no medical condition, substance use, or other mental disorder that could cause the symptoms, diagnose GAD. Here's one last clinical pearl to keep in mind. Similar to panic disorder, a few medical conditions and substances can mimic symptoms of generalized anxiety disorder. These include hyperthyroidism or pheochromocytoma, as well as stimulants like caffeine. If indicated by other history or exam findings, you should rule these out first. Alright, as a quick recap, anxiety disorders are conditions characterized by excessive fear or anxiety and can cause maladaptive changes to thoughts and behaviors. Panic disorder is diagnosed when a patient experiences repeated, unexpected panic attacks and pervasive fear about future panic attacks. Panic disorder can occur with or without agoraphobia. Obsessive-compulsive disorder, or OCD, is characterized by the presence of obsessions and compulsions. Specific phobia is triggered by a single, specific situation or object. Social anxiety disorder occurs when a patient primarily fears being embarrassed or judged in social environments. Finally, generalized anxiety disorder, or GAD, occurs when a patient worries about routine situations and has accompanying physical symptoms.
Trauma is one of the major causes of mortality and morbidity worldwide. A standardized approach to trauma, known as the Trauma Protocol, allows providers to systematically assess and quickly identify potentially life-threatening injuries while simultaneously initiating resuscitation. The Trauma Protocol is composed of primary, secondary, and tertiary surveys, performed one after another. The goal is to first identify life-threatening injuries and stabilize the patient. Then perform a more thorough head-to-toe assessment to catch the not-so-obvious injuries, and finally follow up 24 hours later to make sure no other injuries were missed. This protocol is performed on every trauma patient, regardless of the mechanism of injury. So when a patient presents with trauma, start with a primary survey, which can be summarized as A, B, C, D, and E. A stands for airway. Ensure your patient has an open airway and the ability to maintain a patent airway. Start by asking them their name and what happened. If they can speak, they have an open airway. However, if they show any signs of airway compromise, such as altered mental status, gurgling noises, inability to speak clearly, or evidence of an expanding neck hematoma, secure the airway as soon as possible. In this case, intubate or consider obtaining a surgical airway via cricothyroidotomy. Also, stabilize the C-spine to maintain cervical spine restriction by placing a cervical collar and keeping it in place until a traumatic injury to this area has been ruled out. The next step in the primary survey is B for breathing. This part focuses on identifying any injuries that affect ventilation and oxygenation. Key assessments include checking for tracheal deviation, evaluating for symmetrical chest rise, auscultating for lung sounds, and palpating the chest wall for evidence of trauma. Any injuries that can impair ventilation, such as pneumothorax or hemothorax, should be addressed immediately with bedside procedures such as rapid needle decompression with subsequent chest tube placement, needle thoracocentesis, or tube thoracostomy. Also remember to place supplemental oxygen on all adult trauma patients and monitor oxygen saturation with pulse oximetry. Okay, let's move on to C for circulation. Hypotension in an adult trauma patient is assumed to be from bleeding until proven otherwise, so look for any signs of external or internal bleeding. Additionally, place 2 large-bore intravenous or intraosseous catheters for fluid resuscitation and transfusion of blood products. Be sure to place them away from the area of trauma in case there's a major vascular injury. Finally, monitor their hemodynamic status by observing their level of consciousness, skin perfusion, and vital signs. Now here's a clinical pearl. The chest, abdomen, retroperitoneum, and long bones like the femur are areas that can accommodate large amounts of blood if an internal hemorrhage is present. If you suspect injuries to these areas, keep a close eye on your patient's blood pressure and heart rate, since hemorrhagic shock can occur very quickly. Next up is D for disability, focusing on neurological status assessment. Assess your patient's level of consciousness by calculating the Glasgow Coma Scale, or GCS. Also check pupillary size and reaction to light, and look for signs of spinal cord injury by assessing motor function and sensation in all 4 extremities. Here's another clinical pearl. The GCS is a scoring tool used to assess a patient's neurological condition. It evaluates eye opening, verbal response, and motor response. Eye opening can be assessed as spontaneous, 4 points, to verbal stimuli, 3 points, only to pain stimuli, 2 points, or no response, 1 point. You can remember this by C's, 4 letters for 4 eye points. Similarly, verbal response is evaluated as oriented and coherent, 5 points, confused or inappropriate words, 4 points, incomprehensible sounds, 3 points, verbal response to pain, 2 points, no verbal response, 1 point. Remember this by talks, 5 letters for 5 verbal points. Lastly, motor response has 6 categories. Obeys commands, 6 points, localizing to pain, 5 points, withdraws to pain, 4 points, flexion to pain, also known as decorticate posturing, 3 points, extension response to pain, or decerebrate posturing, 2 points, and no response, 1 point. Remember this by moving, 6 letters for 6 points. Now, the score can range from 15, indicative of a normal functioning patient, to 3, which is indicative of a comatose patient. Any patient with a GCS of 8 or less needs to be intubated. Remember, GCS of 8, intubate. Lastly, let's discuss E for exposure and environmental control. Remove all of your patient's clothing for a thorough assessment and to eliminate any potential contamination. Remember to place warm blankets on your patient to prevent hypothermia. All right, now that the primary survey is completed and your patient has been stabilized, let's discuss the secondary survey. This involves a thorough history and physical examination and additional workup to identify any underlying traumatic injuries that were not obvious during the primary survey. Now, essential components of your patient's history include known allergies, current medications, past illness, pregnancy status, timing of their most recent oral intake, and events related to the injury. The physical exam should follow a head-to-toe sequence and includes obtaining labs and imaging to assist in identifying underlying traumatic injuries. Typical labs include a type and cross, CBC, and CMP. Keep in mind that primary and secondary surveys are not like your typical ABCDE and H&P. They need to be done fast, as there is no time to waste in trauma. Primary survey typically takes 1 to 2 minutes, and H&P portion of the secondary survey usually takes about 5 minutes. Additional tests to consider are ABGs, coagulation studies including a rotational thermoelectrometry, also known as ROTEM, lipase, and serum alcohol level. Also order urine studies like urinalysis, urine pregnancy tests for biological female patients, and urine toxicology screen. Useful imaging studies include a chest and pelvic X-ray and any relevant CT scans that might narrow down your differential. Another important test is a focused abdominal sonography in trauma, or FAST exam, which is a bedside ultrasound that quickly scans the pericardium, hepatorenal space on the right, splenorenal space on the left, and pelvis for evidence of free fluid, which could be from bleeding or hollow viscous injury. Okay, let's discuss some abnormal physical exam findings to look out for during the secondary survey. These include palpating the face to identify maxillofacial trauma, looking for leakage of cerebrospinal fluid from the nose or ears, rolling your patient onto their side to evaluate for spinal tenderness or deformities of the spinal column, palpating the chest for crepitus and the rib cage to identify fractures, and auscultating for muffled heart sounds that could indicate cardiac tamponade. Also, check the abdomen for distension and tenderness, which could indicate solid organ damage. Check for pelvic instability to assess for fracture, and perform a full neurovascular check to identify signs of compromised blood flow or nerve damage. In addition, check for soft tissue injuries and long bone fractures. Provide immediate treatment based on your findings, and remember to administer prophylactic intravenous broad-spectrum antibiotics as needed. Okay, now let's talk about abnormal lab findings. Be on the lookout for low hemoglobin and hematocrit, coagulopathy, acidosis, and an abnormal rotum. If any of these are present, initiate fluid resuscitation and transfusion of blood products if not yet started, and search for the source of bleeding. Moving on, let's talk about abnormal urine studies. The presence of blood in the urine or positive urine toxicology screen warrant prompt evaluation by specialty teams like urology. In addition, a positive urine pregnancy test is concerning in this setting, so alert the obstetrics team immediately. Lastly, let's discuss potential abnormal imaging findings and next steps. Major cardiothoracic injuries, free abdominal air under the diaphragm, and pelvic fracture can typically be identified on chest and pelvic x-rays. A supine chest x-ray can show signs of a pneumothorax, like the deep sulcus sign, where pleural air accumulates at the lateral costophrenic angle. A fast exam can identify free intra-abdominal fluid. Additional injuries are often detected on CT scans, which can include the CT of the head, neck, abdomen and pelvis, spine, and extremities. Abnormal imaging findings require immediate treatment of these injuries, including chest tube placement, pelvic binding, and fracture reduction, as well as evaluation by specialty teams. Now, you should always maintain a low threshold for operative intervention in any adult trauma with abnormal physical exam findings, labs, urine studies, and imaging findings. For example, if they have suffered a severe penetrating injury to the chest that's highly suspicious of injuries to the heart or the great vessels, they'll need to be transferred to the OR for an emergent thoracotomy to identify and repair the injury. Because timing is key to their survival, nothing should delay surgical intervention in these patients. All right, let's discuss the tertiary survey, where you'll ensure you've identified and addressed all of your patient's injuries. A tertiary survey includes a reassessment of your patient's history and physical exam within 24 hours of presentation. The patient's lab tests and imaging studies are reviewed, and additional diagnostic tests are obtained as needed. Based on these findings, prompt treatment and specialty consultation is initiated as indicated. Finally, if your patient experienced a penetrating wound or if their vaccine history is unclear, be sure to administer the Tdap vaccine for tetanus coverage. All right, as a quick recap, the first step in assessing any trauma patient is the primary survey, composed of the ABCDEs. Once your patient is stabilized, you can move on to the secondary survey, which involves a more detailed head-to-toe history and physical exam and obtaining basic trauma labs, urine studies, and diagnostic imaging. Once all major injuries are taken care of, perform a tertiary survey, which is a repeat thorough history and physical exam within 24 hours of your patient presenting to the hospital. Any additional injuries discovered during the tertiary survey should undergo additional workup, consultation, and treatment.
Shock is a life-threatening condition that occurs when inadequate tissue perfusion and oxygen delivery leads to end organ damage and potentially death. Now, the four types of shock include distributive, hypovolemic, cardiogenic, and obstructive. Distributive shock occurs in the setting of excessive systemic vasodilation, leading to impaired blood flow distribution. Next up, hypovolemic shock occurs due to a critical loss of fluid volume. Cardiogenic shock results from a compromise of myocardial performance, leading to a severely decreased cardiac output. Finally, obstructive shock results from obstruction of blood flow from either filling the heart or ejecting into the great vessels, which also ultimately leads to a decreased cardiac output. Now, patients presenting with signs and symptoms of shock will be unstable, So immediately perform an ABCDE assessment and begin acute management. Start by stabilizing their airway, breathing, and circulation. This means that you might need to intubate the patient. Next, obtain IV access and consider giving IV fluids, as well as placing a central venous catheter for administration of medications and hemodynamic monitoring. Additionally, you can insert an arterial catheter for continuous monitoring of the mean arterial pressure, or MAP. Occasionally, you may also place a pulmonary artery catheter, or PAC, to measure certain hemodynamic parameters. Finally, put the patient on continuous vital sign monitoring, including heart rate, pulse oximetry, and blood pressure. Okay, now that you've initiated acute management, it's important to obtain a focused history and physical, as well as order lab tests. Patients may describe generalized weakness, fatigue, lethargy, and postural dizziness. Physical exam typically reveals hypotension and weak peripheral pulses, as well as tachycardia and possibly altered mental status. At this point, you can suspect shock, so your next step is to assess the patient's skin temperature as well as capillary refill time, or CRT. CRT is an indicator of perfusion and is done by squeezing the patient's digit until it blanches, then releasing the pressure and recording the time it takes to go back to its normal color. Normally, this takes 2 seconds or less. Anything longer may be an indicator of poor perfusion due to impaired cardiac output. So, if you notice warm, dry, flushed skin, you should immediately consider distributive shock. In addition, these patients may have a normal CRT. The different causes of distributive shock include sepsis, anaphylaxis, or neurologic injury. First, let's start with septic shock. These patients typically present with fever and symptoms suggestive of a source of infection, such as flank pain. Physical exam might also reveal signs of a source of infection, like costovertebral tenderness, while labs could demonstrate leukocytosis and thrombocytopenia, as well as elevated lactate and inflammatory markers like ESR, CRP, and procalcitonin. These findings should make you consider septic shock, so order blood cultures and imaging like X-ray and CT. If blood cultures are positive and imaging reveals a source of infection, this supports the diagnosis of septic shock. Here's a high-yield fact. Management includes fluid resuscitation, broad-spectrum antibiotics, and vasopressors like norepinephrine or dopamine. Now, here's a clinical pearl to keep in mind. If your patient presents with hypotension, warm skin, and normal CRT in combination with fever, flank pain, and costovertebral tenderness, think of septic shock due to pyelonephritis. Another type is anaphylactic shock. In this case, history typically reveals exposure to a known or suspected allergic trigger, such as food, insect stings, or bites. Important physical exam findings include urticaria and itchy skin, as well as labored breathing, wheezing, and stridor due to airway edema. In these individuals, you should consider anaphylactic shock, so you can order tryptase, which, if elevated, will help confirm the diagnosis of anaphylactic shock. However, keep in mind that tryptase won't peak until 1 to 1.5 hours after the onset of symptoms. As a high-yield fact, management includes immediately removing the allergic trigger and giving intramuscular epinephrine. The least common type of distributive shock is neurogenic shock. History generally reveals brain or high-level spinal cord injury or trauma. In contrast to other types of shock that compensate for low cardiac output by increasing the heart rate, in patients with neurogenic shock, you may see a paradoxical bradycardia due to disruption of autonomic tracts. Additionally, the physical exam might reveal neurologic deficits such as paresis and paralysis. All of these findings should make you consider neurogenic shock, so immediately order a CT scan which may reveal a skull or vertebral fracture, cerebrovascular accident, as well as spinal cord injury. Positive image findings from the CT will support the diagnosis of neurogenic shock. Now let's look at hypovolemic shock, which is characterized by a decrease in intravascular blood volume to a point where tissue perfusion can't be adequately maintained. So, if you notice cold, clammy skin and delayed CRT, then assess your patient for evidence of volume loss. If you see evidence, like from blood loss or dehydration, then consider hypovolemic shock. Hypovolemic shock can be further classified as hemorrhagic or non-hemorrhagic. First, let's start with patients that present with history suggesting a bleeding source, most commonly due to trauma or blood loss from the gastrointestinal or genitourinary tracts. These individuals often present with hematemesis, melena, or hematochezia, but sometimes there might be no visible sign of bleeding. Additionally, CBC reveals low hemoglobin, which helps confirm blood loss. At this point, you should consider hemorrhagic shock. So, your next step is to order imaging methods like ultrasound and CT, as well as diagnostic procedures such as EGD or colonoscopy to visualize the bleeding source, which, if found, supports the diagnosis of hemorrhagic shock. Now, let's take a look at non-hemorrhagic shock. These individuals report a history of vomiting, diarrhea, or burns. In this case, physical exam often reveals decreased skin turgor, dry mucous membranes, as well as decreased urine output. Additionally, CBC reveals high hemoglobin, which suggests hemoconcentration. These patients should make you think of non-hemorrhagic shock. So, the next step is to assess each organ system for the cause of fluid loss. In patients who describe excessive diarrhea or vomiting, think of gastrointestinal causes like irritable bowel syndrome or GI infection. On the other hand, if your patient presents with severe blistering or eschar formation, consider burn injury. Either of these will support the diagnosis of non-hemorrhagic shock. Here's a high-yield fact. Management of hypovolemic shock includes addressing the underlying cause, while also giving IV fluids, or even blood transfusions if needed. Keep in mind that vasopressors are typically not recommended here, since they can further decrease tissue perfusion. Okay, let's go over the last two categories of shock, starting with cardiogenic shock. When treating patients that have cold, clammy skin and delayed CRT with no evidence of blood or fluid loss, you should consider either cardiogenic or obstructive shock. So, if you suspect cardiogenic shock, you should immediately order labs, including cardiac enzymes and BNP, ECG, and imaging such as transthoracic echocardiography, or TTE for short. These diagnostic methods will help you differentiate between the most common causes of cardiogenic shock: heart failure and myocardial infarction. Let's start with heart failure. These individuals usually report shortness of breath and fatigue. Physical exam often reveals signs of volume overload, such as peripheral edema, crackles, and jugular venous distension, but keep in mind that some patients can also occasionally present without volume overload. Laboratory studies will typically show an elevated BNP, while a TTE might demonstrate systolic or diastolic dysfunction, structural changes, or valvular incompetence. With these findings, you can have confidence that the diagnosis is heart failure. Another important cause is myocardial infarction. These patients typically report a squeezing substernal chest pain that radiates to the arm and might be diaphoretic on a physical exam. Additionally, ECG findings can include ST elevations, while labs reveal elevated cardiac enzymes, which confirm the diagnosis of myocardial infarction. Now, let's go back to obstructive shock. So, if you suspect obstructive shock, history and physical should point to the most likely underlying cause and guide your next steps in management, such as labs or imaging. These diagnostic methods will help you differentiate between the most common causes of obstructive shock, such as pulmonary embolism, cardiac tamponade, and tension pneumothorax. First, let's start with pulmonary embolism, which is typically associated with pleuritic chest pain, hemoptysis, and a history of DVT. Physical exam findings usually include tachypnea as well as unilateral leg swelling, while labs might reveal a high D-dimer level. In these patients, use Wells criteria and imaging, primarily CTPA, to diagnose pulmonary embolism. Moreover, Wells score above 2 and filling defects on CTPA confirm the diagnosis of pulmonary embolism. On the other hand, in cardiac tamponade, individuals usually report chest pain that's relieved by sitting up and leaning forward. The classic physical findings, known as the Beck triad, include hypotension, jugular venous distension, and muffled heart sounds. Chest X-ray might reveal a widened mediastinum and a water bottle sign, where the cardiac silhouette appears enlarged and stretched. Diagnosis of cardiac tamponade can be confirmed via echocardiogram, which typically shows pericardial effusion as well as the diastolic collapse of the right atrium and ventricle. Finally, let's look at tension pneumothorax, which is associated with the history of sudden and severe chest pain and shortness of breath, as well as physical exam findings, such as shallow breathing, tachypnea, absent breath sounds on the affected side, and tracheal deviation toward the opposite side. Remember that tension pneumothorax is a clinical diagnosis based on history and physical, so it doesn't need further testing. Here's a clinical pearl. If you suspect tension pneumothorax, proceed with emergent needle decompression to release trapped air from the chest cavity. Once released, the patient's general condition will immediately improve. This confirms the diagnosis of tension pneumothorax. Sometimes, you can order a chest X-ray to detect a visible visceral pleural edge with absent distal lung markings on the affected side, as well as tracheal deviation and mediastinal shift toward the opposite side. Now, one last high-yield fact. While not routinely used in clinical practice, placement of a pulmonary artery catheter, or PAC, can be useful in the differentiation of one type of shock from another, as well as help guide hemodynamic resuscitation efforts, like the rate of IV fluid infusion and the decision to use vasopressors or inotrope. PAC parameters commonly utilized include pulmonary capillary wedge pressure, or PCWP, which gives an indirect measure of left atrial pressure. Central venous pressure, or CVP, is a reflection of right atrial pressure. Systemic vascular resistance, or SVR, is the afterload, or the resistance to blood flow in the peripheral arteries. Cardiac index, or CI, indicates the cardiac output from the left ventricle. And finally, venous oxygen saturation, or SVO2, measures the oxygen saturation in venous blood. In cardiogenic shock, PAC values you'll see include an increased PCWP and CVP, increased SVR, and decreased CI and SVO2. In obstructive shock, PAC will reveal a decreased PCWP, except in tamponade, where PCWP can be paradoxically increased, as well as increased CVP, increased SVR, and decreased CI and SVO2. In hypovolemic shock, your PAC values will reveal a decreased PCWP and CVP, increased SVR, and decreased CI and SVO2. In distributive shock, your PAC values will reveal a decreased PCWP and CVP, decreased SVR, and increased CI and SVO2 in sepsis or anaphylaxis, but decreased CI and SVO2 in neurogenic shock. Also, keep in mind that there are minimally invasive and non-invasive hemodynamic monitoring devices that can be used as alternatives to PAC. Alright, as a quick recap. Shock is a life-threatening condition that needs to be diagnosed and treated quickly. Patients with shock are unstable and require airway support, IV fluid resuscitation, and vital sign monitoring. Once you suspect shock, assess the patient's skin temperature and CRT. Warm, dry, flushed skin and a normal CRT suggest distributive shock, such as septic, anaphylactic, and neurogenic shock. On the other hand, if you notice cold, clammy skin and delayed CRT, assess for evidence of volume loss. Volume loss is associated with hypovolemic shock, further classified as hemorrhagic or non-hemorrhagic. If there's no evidence of blood or fluid loss, think of cardiogenic shock, most commonly due to myocardial infarction and heart failure, or obstructive shock, which can occur due to pulmonary embolism, cardiac tamponade, and tension pneumothorax.
Brain death is defined as the irreversible loss of all brain functions that results in permanent loss of consciousness, brainstem reflexes, and spontaneous respirations. Important causes of brain death include trauma, stroke, hypoxic ischemic injury, mass lesions, infections, and toxic or metabolic disorders. As with death by cardiopulmonary criteria, declaring brain death means declaring the death of the patient. Now, if your patient presents with coma, which could be a sign of brain death, first, perform an ABCDE assessment. You should always consider these patients unstable, so begin acute management immediately. Stabilize the airway, breathing, and circulation. This means that you will need to intubate the patient and place them on mechanical ventilation. Next, obtain IV access and begin continuous vital sign monitoring, including blood pressure, heart rate, and pulse oximetry, as well as cardiac telemetry. Once you stabilize the patient, obtain a focused history and physical examination, as well as labs, including a complete metabolic panel, toxicology screen, and alcohol level. Also, don't forget to order an MRI or CT of the brain. History will reveal a recent loss of consciousness, often in combination with an event that led to a catastrophic brain injury, such as head trauma and stroke, as well as drowning, choking, or cardiac arrest, which can result in hypoxia and anoxia. Additionally, there might be a recent brain infection or toxic ingestion. Brain death might also occur as a result of renal or hepatic failure, which can lead to severe metabolic derangements and subsequent cerebral edema. On physical examination, your patient will have an altered mental status, meaning they will be unconscious and unresponsive to visual, auditory, and tactile stimuli. They will not have cerebrally mediated motor responses like eye-opening or localizing to painful stimuli such as nail bed pressure or sternal rub. Additionally, brainstem reflexes will be absent bilaterally. First, be sure to check for pupillary reflexes. Shine a bright light into each eye and assess for pupillary constriction. Next, check corneal reflexes. Apply a tactile stimulus, such as a cotton tip, to each cornea and look for eye blinks. Next up is the oculocephalic reflex. Hold the patient's eyes open and move the patient's head quickly from side to side and up and down. If the eyes stay midline relative to the head position throughout the range of head movement, oculocephalic reflexes are absent. Next, test the oculovestibular reflexes using the caloric reflex test. Insert cold water into each ear canal and look for any eye movement, including nystagmus. Now, keep in mind that the oculocephalic and oculovestibular reflexes test the same cranial nerves, but the oculovestibular reflex test provides a stronger stimulus. If you can't assess the oculocephalic reflexes, such as in the case of cervical spine injury, you could still declare brain death if the oculovestibular reflexes are absent bilaterally. However, if you can't assess the oculovestibular reflexes, for example, if there's a significant ear trauma, testing the oculocephalic reflexes alone is not sufficient. Finally, to test the gag and cough reflexes, insert an object such as a cotton tip, tongue blade, or suctioning catheter into the mouth and touch the back wall of the oropharynx. If your patient is intubated, you can also assess the cough reflex using the endotracheal tube suctioning catheter. Now, here's a clinical pearl to keep in mind. Even in brain death, spinally mediated reflexes can be present. Continue with your evaluation. Examples include deep tendon reflexes and the Lazarus sign, which refers to elevation and flexion of the arms that subsequently fall to the chest, something similar to the position Egyptian mummies have. Moving on to labs. The complete metabolic panel might be normal, while the toxicology screen should be negative, and the serum alcohol level should be undetectable. CT scan or MRI of the brain will show cerebral edema, which may have progressed to brain herniation. It might also show diffuse loss of gray-white matter differentiation, intracranial hemorrhage, infarction, or a brain mass. With these findings, you should suspect brain death, so your next step is to assess other prerequisites for brain death determination. You want to be sure that there are no false declarations, so there is a strict list of criteria that your patient has to meet. First, observe the patient for at least 24 hours to ensure there is no improvement. Next, assess if any medications were given that could potentially affect consciousness or blunt brainstem reflexes. For example, if the patient previously received barbiturates, make sure that the medication level is not therapeutic or supratherapeutic. If levels are not testable, you should wait at least 5 half-lives of the medication. Next, there should be no severe metabolic or acid-based derangements. If these are present, correct them if possible. Next, the patient should not be pharmacologically paralyzed. Finally, the body temperature should be at least 36 degrees Celsius. The systolic blood pressure should be 100 millimeters of mercury or greater, and the mean arterial pressure 75 millimeters of mercury or greater. In other words, be sure to rewarm your patient and raise the blood pressure because hypothermia and hypotension can blunt neurologic function. If your patient meets these prerequisites, your next step is to evaluate for spontaneous respiratory effort using apnea testing. This test assesses spontaneous breathing in the setting of hypercarbia and acidosis, which would normally trigger the respiratory center in the brainstem and tell the body to breathe. Before starting the test, make sure your patient is adequately oxygenated to minimize the risk of hypoxia and potential organ injury. You can check this by obtaining an arterial blood gas. This way, you can be sure that pH values and partial pressures of oxygen and carbon dioxide are within normal limits. Next, disconnect the ventilator while still providing oxygenation down the endotracheal tube. During this step, closely look for any signs of breathing. Keep in mind that you should abort the test if the patient becomes hypoxic or hemodynamically unstable, because you will be risking further organ damage if there's no brain death. If spontaneous respirations are present, there's no brain death, so abort the apnea test immediately and reconnect the ventilator. In this case, consider alternative diagnoses such as coma or non-convulsive status epilepticus. However, if there is no evidence of spontaneous respirations, the carbon dioxide will begin to build up in the body, so repeat blood gas and assess for hypercarbia and acidosis. Hypercarbia and acidosis are consistent with apnea, meaning the test is positive, so you can declare brain death. Now, here's a clinical pearl to keep in mind. There are situations where you cannot complete a clinical brain death evaluation and must obtain ancillary tests to confirm brain death. Examples of such situations include facial or ear trauma precluding brainstem reflex testing, the presence of motor movements that are not clearly spinally mediated, severe metabolic derangements that you can't correct, or intolerance of apnea testing because of hypoxia or hypotension. In these situations, obtain ancillary testing to assess for the presence of blood flow and perfusion in the brain using 4-vessel catheter angiography, radionuclide perfusion imaging, or transcranial Doppler ultrasonography. Once you confirm brain death, declare a time of death, inform your patient's family or power of attorney, and provide counseling and support. You should notify the appropriate organ donation organization or team. However, you should not be involved in the organ transplant evaluation or decision-making since you have been caring for this patient. This is considered a conflict of interest for you that can directly benefit another patient. If organ donation is not elected, you should allow loved ones some time with the deceased and later withdraw mechanical and pharmacologic support. Now, here's one last clinical pearl to keep in mind. A brain death evaluation in children differs in a few ways from a brain death evaluation in adults. First, in children younger than 2 years old, the observation should be at least 48 hours. Next, you should maintain the blood pressure at or above the 5th percentile for age. In addition to the other brainstem reflexes, in children younger than 6 months of age, you should also check sucking and rooting reflexes. Finally, the clinical exam, including the apnea test, must be performed by 2 different examiners. All right, that's a quick recap. Brain death is defined as the irreversible loss of all brain function due to catastrophic injury, resulting in permanent loss of consciousness, brainstem reflexes, and spontaneous respirations. The clinical exam will demonstrate no response to stimuli, absent brainstem reflexes, and no spontaneous respirations. If you cannot perform a part of the clinical exam, consider ancillary testing. Once you declare brain death, provide family counseling and support, contact the appropriate organ donation organization, and if organ donation is not elected, withdraw mechanical and pharmacologic support. COVID-19 is a respiratory infection caused by SARS-CoV-2, a highly contagious virus that primarily spreads via respiratory droplets. Once in the respiratory tract, the virus replicates and causes symptoms similar to the common cold, while in some cases the virus causes a robust inflammatory response that can produce life-threatening illness. Based on clinical manifestations, COVID-19 can be mild, moderate, severe, or critical. Now, if your patient presents with chief concerns suggesting COVID-19, you should first perform an ABCDE assessment to determine if your patient is unstable. If the patient is unstable, stabilize their airway, breathing, and circulation. This might require you to intubate the patient and provide mechanical ventilation. Also, don't forget to obtain IV access and place your patient on continuous vital sign monitoring, including heart rate, blood pressure, and pulse oximetry. Once you stabilize the patient, obtain a focused history and physical exam, but also labs, such as a SARS-CoV-2 test, an arterial blood gas, or ABG, a CMP, inflammatory markers, including CRP and ESR, as well as a D-dimer, BNP, troponin, and lactate. You should also obtain a chest X-ray and ECG. Typically, patients report respiratory symptoms such as cough, rhinorrhea, nasal congestion, as well as shortness of breath and difficulty breathing. They may also report new loss of taste or smell. Often, systemic symptoms like headache, fatigue, myalgia, and fever are associated. Some patients may also experience gastrointestinal symptoms like nausea, vomiting, or diarrhea. Additionally, patient history can reveal a known SARS-CoV-2 exposure. On physical exam, you can find evidence of respiratory distress, such as hypoxemia, as well as rales or rhonchi on auscultation, and accessory muscle use and retractions. In severe cases, your patient can be hypotensive as well. As for labs, these will reveal a positive SARS-CoV-2 test. The ABG and CMP can show respiratory alkalosis, and CRP and ESR are typically elevated. Depending on the severity of the illness, the patient could also have elevated D-dimer, BNP, troponin, or lactate levels. Now, the chest X-ray typically shows ill-defined, patchy, ground glass opacities that are predominantly peripheral and typically affect the lower lobes. But keep in mind that in some cases, it may not show abnormalities. Finally, the ECG could show heart rate or rhythm abnormalities, as well as ischemic changes such as ST segment depression or T-wave inversions. Now, here's a clinical pearl. Some medications used to treat COVID-19 can prolong the QTC interval, so having an initial ECG is important to help trend and ensure the QTC interval does not become too prolonged. They can also increase liver enzymes, so having baseline and follow-up liver function tests is important to monitor for hepatotoxicity. Okay, at this point, you can diagnose critical COVID-19. Often, these patients require aggressive respiratory support, so based on the patient's degree of respiratory distress, you can start either the high-flow nasal cannula, non-invasive ventilation, invasive ventilation, or even ECMO. All patients should receive systemic corticosteroids, as well as an immunomodulator to decrease inflammatory-mediated injury, but also remdesivir to directly target the virus. Next, put all patients on a prophylactic dose of anticoagulation, often preferably low molecular weight heparin, since COVID-19 can cause thrombotic complications. Finally, if your patient is hypotensive, start vasopressors to maintain adequate blood pressure and organ perfusion. Now, here's a clinical pearl to keep in mind. Monoclonal antibodies against SARS-CoV-2 have been shown to provide clinical benefit in treating COVID-19, but their efficacy depends on the viral strain. Okay, now let's go back to the ABCDE assessment and take a look at stable patients. If your patient is stable, proceed with a focused history and physical exam. The history commonly reveals respiratory symptoms such as cough, rhinorrhea, or nasal congestion, and a new loss of taste or smell, as well as gastrointestinal symptoms like nausea, vomiting, or diarrhea. Again, keep in mind systemic symptoms such as headache, myalgias, fatigue, and fever. Many patients also have a known SARS-CoV-2 exposure. On the other hand, physical exam findings typically include rales and rhonchi, and in moderate and severe forms, dyspnea and tachypnea. Next, obtain a SARS-CoV-2 test and check your patient's oxygen saturation on room air using pulse oximetry. Let's talk about different severities of COVID-19. If your patient is SARS-CoV-2 positive and has an oxygen saturation greater than or equal to 94% on room air, the next step is to assess for dyspnea. If your patient is not dyspneic, then they may have mild COVID-19. However, if your patient is dyspneic, diagnose moderate COVID-19. In both cases, your next step is to determine whether or not your patient has any risk factors known to increase the risk of progressing to severe COVID-19. These risk factors include being 65 years or older, being unvaccinated, being immunosuppressed, or having medical comorbidities, such as chronic lung conditions, malignancy, diabetes mellitus, or obesity. If the patient doesn't have any of these risk factors, treatment includes supportive care only. On the other hand, if the patient has one or more risk factors, treat with ritonavir-boosted nirmatrelvir or, if unavailable, remdesivir. Now, here's a clinical pearl. Vaccination is the most effective way to prevent COVID-19 or prevent progression to severe forms of the disease. In the United States, 4 vaccines have been authorized to prevent the disease. A primary series is recommended for all eligible individuals over the age of 6 months. The type of vaccine and dosing recommended varies based on the patient's age and the presence of underlying medical conditions. Okay, now let's go back and take a look at patients that are SARS-CoV-2 positive and have an oxygen saturation of less than 94% on room air. In this case, you should diagnose severe COVID-19 and put your patient on enough supplemental oxygen to achieve a blood oxygen saturation of 94% or higher. Next, give systemic corticosteroids as well as remdesivir. All patients with severe COVID-19 should also receive a prophylactic dose of a parenteral anticoagulant like low molecular weight heparin. Here's one last clinical pearl. The impact of having COVID-19 can sometimes last weeks or months after the initial infection. Patients who have persistent symptoms of COVID-19 more than 4 weeks after their initial diagnosis may develop long COVID or post-COVID-19 syndrome, which can cause significant morbidity. COVID-19 can also be associated with a condition known as multisystem inflammatory syndrome in adults, or MIS-A for short. Who gets MIS-A and why it is not well understood, but the condition occurs days to weeks after an initial SARS-CoV-2 infection. It is characterized by subjective or documented fever for at least 24 hours, in addition to either cardiac dysfunction, a rash, or non-purulent conjunctivitis. Additional findings can include new-onset neurologic symptoms, shock, or hypotension, abdominal pain with vomiting or diarrhea, and thrombocytopenia. Additionally, labs must document an elevation of at least 2 inflammatory markers and current or recent SARS-CoV-2 infection. All right, as a quick recap, if a patient presents with chief concerns suggesting COVID-19, first perform an ABCDE assessment to determine if your patient is unstable or stable. Unstable patients usually present with critical COVID-19 and require respiratory support, either with a high-flow nasal cannula, non-invasive ventilation, invasive ventilation, or even ECMO. Additionally, you should give systemic corticosteroids, immunomodulators, and remdesivir, as well as anticoagulants and vasopressors if needed. On the other hand, if your patient is stable and has mild or moderate COVID-19, proceed with supportive care or consider medications such as ritonavir-boosted nirmatrelvir or, if unavailable, remdesivir. Finally, in patients with severe COVID-19, the treatment includes supplemental oxygen, corticosteroids, remdesivir, and anticoagulants.
At the neurology department, a 60-year-old male named Oliver is brought in by his son because lately Oliver has become more aggressive, impolite, and he seems to have lost his interest in his family. Recently, he has also started repeating conversations. Next, there's a 72-year-old female named Iris, who is also brought in by her son. Iris is always staying at home because she's embarrassed that she's unable to hold her urine. She also has a hard time finding her things at home because she forgets where she's placed them. Her son has noticed that she's walking strangely, as if her feet stick to the ground. And finally, there's a 35-year-old male named Alistair, who's brought in by his partner because in the past few weeks he's started repeating conversations and misplacing their belongings. Alistair also has episodes of jerking movements of his left arm, and he's fallen twice in the last few days. His medical history reveals a corneal transplantation 6 months ago. Okay, so all of these people have dementia. Dementia occurs when there's a decline in at least one cognitive function, and it impairs daily functioning. Remember that they need to have intact consciousness. Dementia can result from reversible and irreversible causes. Reversible causes include alcohol dependence, hypothyroidism, vitamin B12 deficiency, neurosyphilis, normal pressure hydrocephalus or NPH, and depression. Irreversible causes include Alzheimer's disease, which is by far the most common cause of dementia, vascular dementia, which is the second most common cause, frontotemporal dementia, Lewy body dementia, Parkinson's disease, Huntington disease, and Creutzfeldt-Jakob disease, or CJD. Okay, so let's take a closer look at the irreversible causes of dementia, starting with Alzheimer's disease, which is a very high-yield topic for the exams. In the cell membrane of a neuron, there's a molecule called amyloid precursor protein, or APP. Normally, old APP gets chopped up by two enzymes called alpha secretase and gamma secretase to a soluble peptide. But if another enzyme called beta secretase teams up with gamma secretase instead, then the chopped up fragment isn't soluble, and it creates a monomer called amyloid beta. For the test, remember that these amyloid beta monomers bond together outside the neurons and form beta amyloid plaques. These plaques get between the neurons and impair brain function. Also, it's important to know that amyloid plaque can deposit around blood vessels in the brain, causing amyloid angiopathy, which weakens the walls of the vessels and increases the risk of hemorrhage. Alright, now neurons are held together by their cytoskeleton, which is partly made up of microtubules, which also form tracks along the cells to ship nutrients and molecules. A protein called tau makes sure that these tracks don't break apart. And it's thought that the beta amyloid plaques outside the neuron initiate pathways inside the neuron that lead to activation of kinase, an enzyme that transfers phosphate groups to the tau protein. The tau protein stops supporting the microtubules, gets tangled with other tau proteins, forming neurofibrillary tangles inside the neuron. This makes Alzheimer's disease a tauopathy. Okay, so remember, the tangles are found inside the cell, as opposed to the beta amyloid plaques that are found outside the cells. Neurons with tangles and non-functioning microtubules can't function, and end up undergoing apoptosis. The number of neurofibrillary tangles increases as the disease progresses. In addition, low acetylcholine levels in the nucleus basalis and the hippocampus also contribute to the cognitive symptoms seen in Alzheimer's disease. This is due to impaired activity of an enzyme responsible for acetylcholine synthesis, called choline acetyltransferase in these areas of the brain. Okay, now Alzheimer's disease can either be sporadic or familial. Sporadic is used to describe the late onset type, which is probably a combination of genetic and environmental risk factors, and accounts for a majority of the cases. A gene that's been identified as possibly contributing is the E4 allele of apolipoprotein E gene, or APOE-E4. Apolipoprotein E helps break down beta amyloid, but the E4 allele seems to be less effective than the other alleles, meaning patients are more likely to develop beta amyloid plaques. Okay, now familial Alzheimer's disease is used to describe cases with early onset Alzheimer. This can be caused by several gene mutations and accounts for about 5 to 10% of cases. For example, mutations in the PSEN1 or PSEN2 genes on chromosome 14 or chromosome 1 respectively have been linked to early onset Alzheimer. These genes encode for presenilin 1 and presenilin 2, both protein subunits of gamma secretase. Mutations in these genes change the location where gamma secretase chops up APP, producing different length beta amyloid molecules, which seem to be better at clumping up and forming plaques. Another known genetic cause of Alzheimer is trisomy 21, or Down syndrome. The gene responsible for producing APP is located on chromosome 21, which means that individuals with Down syndrome have an extra APP gene, potentially increasing the amount of amyloid plaque buildup. Next up is vascular dementia, where there's a progressive loss of brain function caused by long-term poor blood flow to the brain. Vascular dementia develops when atherosclerosis starts to form in the arteries supplying the brain, like the internal carotid arteries. This leads to a gradual decrease in blood flow to the brain, which is called chronic ischemia. Sometimes small parts of the plaques can break away and can eventually block a smaller artery, completely stopping the blood supply to the parts of the brain. Other times, the tiny perforating arteries are affected by atherosclerosis and can get completely blocked off by plaque growing within them. Regardless of the cause, once blood supply to the brain falls below the demands of the tissue, it's considered an ischemic stroke. The tissue damage from an ischemic stroke is usually permanent and the dead tissue liquefies in a process called liquefactive necrosis. Brain tissue necrosis leads to a loss of mental functions governed by that area. Now, if another stroke happens later on, more brain tissue might die off. Over time, this damage gets worse and worse, and the final result is dementia. This is referred to as multi-infarct dementia, and it's a subtype of vascular dementia that you have to remember for your exams. Next is frontotemporal dementia. For the test, remember that frontotemporal dementia refers to atrophy of the frontal lobes that eventually progresses to the temporal lobes, with relative sparing of the parietal and occipital lobes. A high-yield subtype of frontotemporal dementia is Pick disease, which is characterized by the presence of Pick bodies, which are tangles of tau proteins. Tau comes in different isoforms, like the 3R and the 4R isoforms. In Pick disease, 3R isoforms get hyperphosphorylated, change shape, and stop being able to tie together the microtubules in the neuron's cytoskeleton. They also start clumping together, forming tangles. So Pick disease is a tauopathy, like Alzheimer's disease. A key difference is that the tangles in Pick disease are called Pick bodies, and they're only made up of the 3R isoforms, whereas the neurofibrillary tangles in Alzheimer's disease are made up of both 3R and 4R tau isoforms. Now, neurons with loads of tangles and non-functioning microtubules don't function well, and the neurons undergo apoptosis. Okay, so next is Lewy body dementia. The underlying cause of Lewy body dementia isn't well understood. Normally, neurons contain a protein called alpha-synuclein, and in Lewy body dementia, this protein gets misfolded within the neurons. The misfolded alpha-synuclein aggregates to form Lewy bodies that deposit inside neurons, particularly in the cortex and the substantia nigra. Under a microscope, Lewy bodies look like dark eosinophilic inclusions inside the affected neurons. As the disease progresses, more and more neurons accumulate Lewy bodies and die. The significance of Lewy bodies, however, is unknown, but remember that they're also seen in other diseases, like Parkinson's disease. Alright, now Parkinson's disease can also cause dementia. This is a slowly progressive genetic disorder that primarily affects individuals over 50 years old. It's characterized by the loss of dopamine-producing or dopaminergic neurons in the substantia nigra, which is a part of the basal ganglia. Normally, within the basal ganglia, there's a balance between dopamine, which promotes movement, and acetylcholine, which inhibits movement. In Parkinson's disease, the loss of dopaminergic neurons results in less movement, difficulties in speech and swallowing, as well as cognitive symptoms like dementia in the later stages of the disease. Next, there's Huntington disease, which is very high yield. So Huntington disease is an autosomal dominant neurodegenerative disorder that typically affects individuals around 40 years of age. It's caused by a mutation in the Huntington disease or HD gene on chromosome 4. This gene contains a CAG trinucleotide repeat, which encodes for the amino acid glutamine. The gene encodes for a protein called huntingtin. The mutated protein aggregates within the neuronal cells of the caudate and putamen of the basal ganglia, causing neuronal cell death. So the caudate and the putamen of the basal ganglia are the areas of the brain affected in Huntington disease. The brain regions affected by Huntington disease have decreased GABA and acetylcholine and increased dopamine levels. There's also excessive activation of a subtype of glutamate receptors called NMDA receptors that leads to glutamate excitotoxicity, a process by which neurons are damaged. Over time, if enough neurons die in the caudate and putamen, which together form the dorsal striatum, this can cause actual loss of brain tissue volume in these areas, which can expand to the lateral ventricles. These areas of the brain play an important role in movement, particularly inhibiting it, and that's why Huntington disease causes movement problems like chorea and athetosis. but they also have cognitive symptoms like dementia. Now, another high-yield concept about Huntington disease is a phenomenon called anticipation, which is where there's an increased number of trinucleotide repeats in subsequent generations. This leads to an earlier onset and more severe presentation of the disease. This process of adding more repeats is called repeat expansion. It happens way more in the production of sperm than eggs, and so anticipation generally occurs when the biological father is the affected parent. Finally, a rare cause of dementia is Creutzfeldt-Jakob disease, or CJD. CJD is the most common cause of spongiform encephalopathy, and it's a high-yield topic for your exams. Spongiform encephalopathy refers to a group of neurodegenerative diseases caused by the accumulation of infectious misfolded proteins, called prions. Misfolded means that they change from having mostly alpha helices to having a lot of beta-pleated sheets. And so, they become resistant to being broken down by proteases. When a misfolded prion protein enters a neuron, it induces a misfolding of the normal prion proteins found inside the cell. As a result, prions accumulate within the neuron and trigger apoptosis with the help of an intracellular 14-3-3 protein. When large numbers of neurons die, the brain gets replaced by cysts, making it look like a sponge. That's why these diseases are called spongiform encephalopathies. Now, there are actually 4 types of CJD: familial, or FCJD, variant, or VCJD, iatrogenic, or ICJD, and sporadic, or SCJD. Familial Creutzfeldt-Jakob disease occurs when there is a mutation in the PRNP gene, which encodes for the prion protein. Variant Creutzfeldt-Jakob disease is caused by eating the meat of cows with prions in the muscle tissue. In cows, these prions cause bovine spongiform encephalopathy, which is more commonly called mad cow disease. When sheep are fed cow meat, the prion causes the disease scrapie. If a person eats the meat of affected cows or sheep, the prions get absorbed through the intestines into the bloodstream. The protein can somehow get through the blood-brain barrier and then enters neurons by a process called absorptive endocytosis. Absorptive endocytosis is a process where the plasma membrane of the nerve cell folds inwards to bring in substances that otherwise would not be able to cross the plasma membrane by themselves. Iatrogenic Creutzfeldt-Jakob disease is caused by medical procedures, like a corneal transplant, where the transplanted organ or the instruments gets contaminated by prions. Finally, there's sporadic Creutzfeldt-Jakob disease, which pops up in populations randomly without a clear cause. Now let's quickly go over the reversible causes of dementia. Common ones include chronic alcohol use, hypothyroidism, vitamin B12 deficiency, or tertiary syphilis. Another important reversible cause is depression, and cognitive impairment due to depression is referred to as pseudodementia. A key finding in pseudodementia is that individuals are often anxious about their memory impairment, as opposed to other causes of dementia like Alzheimer's disease. A very high-yield reversible cause of dementia is normal pressure hydrocephalus, or NPH. NPH typically occurs in the elderly, so it's often misdiagnosed as Alzheimer's disease. It's caused by abnormal venous drainage of the cerebrospinal fluid, resulting in hydrocephalus. Since the frontal lobe is the most affected, individuals with NPH usually present with urinary incontinence and gait disturbance at first, and then dementia. Now let's switch gears and talk about clinical presentation. Although all these disorders can cause dementia, many of them also cause other symptoms that will be key clues for the correct diagnosis. But before that, let's take a look at how dementia typically presents. Most of the time, a close family member or friend notices the individual's change in cognition. This includes impaired memory, which leads to repeating conversations or misplacing belongings. Language impairment can make it hard to think of common words. Additionally, Concentration and executive function are impaired, so individuals have a hard time with complex tasks like managing their finances. Visual spatial impairment can prevent them from recognizing faces and navigating in familiar locations. Sometimes, family members also notice changes in the individual's personality. Okay, now there are specific symptoms that can help you identify the different causes of dementia. For the exams, remember that Alzheimer's disease has an insidious onset and gradual progression. Individuals usually go through 3 phases. First is the asymptomatic phase. Second is a pre-dementia phase called mild cognitive impairment, during which there's gradual onset of memory impairment without much impairment in other cognitive domains, and no impairment in daily functioning. This differs from normal aging because the memory impairment is greater than expected for the individual's age. The third phase is the dementia phase, and that's where individuals develop more significant memory loss, followed by slow, gradual loss of the other cognitive functions, such as language, visuospatial, and executive functions. Now there are 2 main types of memory: episodic memory, which is memory of events, and semantic memory, which is memory of words and vocabulary. Early on, episodic memory is impaired, but semantic memory remains intact. Later on, both episodic and semantic memory get impaired. Episodic memory can be subclassified into immediate, recent, or long-term. Immediate memory is sometimes called procedural memory, and it's the memory you use to repeat back a phone number right away. Recent memory is the memory you use to remember a list of 3 words 5 minutes later, like those 3 words from earlier. This is a type of memory that's impaired early on in Alzheimer's disease because the disease affects the hippocampus first, which is responsible for recent memory. Long-term memory is a memory of events that have occurred years ago, and these aren't impaired until late in the course of this disease. For example, an individual with Alzheimer's may remember details of their wedding 50 years ago, but they won't be able to remember where they were yesterday. Now, symptoms of vascular dementia vary depending on which region of the brain is damaged. For example, if someone has strokes in the temporal lobe, it might be difficult for them to remember things or make new memories. Someone with a stroke in the left parietal lobe might lose the ability to speak, which is called an aphasia. But then if they get another stroke in the frontal lobe, their personality might begin to change. One thing that's constant is that the symptoms of dementia appear suddenly, and brain function decreases with each stroke. Another characteristic finding in vascular dementia is that individuals have neurological deficits which correspond to the region of the brain that's affected by the stroke. They can also have other manifestations of atherosclerosis, like coronary artery disease, and other comorbidities that increase the risk of stroke, like hypertension and diabetes. Now, in multi-infarct dementia, there's a characteristic stepwise decline in cognitive function. For example, the individual develops a stroke, and then, as a consequence, demonstrates a sudden decline in their memory. Then, in between stroke events, there is no progression of their cognitive dysfunction until another stroke occurs, and they suddenly lose another cognitive domain, such as language, and so on. This pattern, alongside a temporal relation to the stroke, is what differentiates it from Alzheimer's disease, where the decline in cognitive function is steady and gradual. Also, unlike in Alzheimer's disease, where recent memory is usually lost first, the pattern of cognitive decline in vascular dementia varies depending on which area was infarcted. Individuals with frontotemporal dementia usually present before the age of 65. And it's very important to remember for the test that early on, they have behavioral symptoms, with relative sparing of memory defects. These symptoms include personality changes, impaired judgment, apathy, and disinhibition. They also have perceptual motor functional loss, meaning individuals struggle with things like hand-eye coordination or body-eye coordination. There are 2 variants of frontotemporal dementia. In the behavioral variant, first, there are 3 or more of the following 5 symptoms: disinhibition, apathy or inertia, loss of sympathy or empathy, stereotyped, compulsive, or ritualistic behavior, hyperorality, which is when people put inappropriate objects in their mouth, and dietary changes. And second, there's a decline either in social cognition or in executive abilities, which are a set of skills necessary to adapt to the environment and to achieve goals. The language variant is when there's a prominent decline in language skills, or aphasia. Individuals have difficulty in speech production, word finding, object naming, grammar, or word comprehension. Okay, now two very similar types of irreversible dementia syndromes are Lewy body dementia and Parkinson's disease dementia. Both include dementia and Parkinsonism, a term used to describe the movement disorder in both diseases. The symptoms of Parkinsonism can be remembered with the mnemonic TRAP. T for tremor, R for rigidity, A for akinesia or bradykinesia, which is absence or slowness of movement, and P is for postural instability. Lewy body dementia is distinct from dementia secondary to Parkinson's disease in that the onset of dementia occurs before the onset of motor symptoms, and this takes place less than 1 year apart. In Parkinson's disease, motor symptoms develop first, and it can take many years before the onset of dementia. Other features of Lewy body dementia include recurrent episodes of having vivid visual hallucinations, and fluctuating episodic deficits in attention and alertness, which may be confused with delirium. In addition, individuals with Lewy body dementia can have sleep behavior disorder, where individuals move a lot while sleeping. Okay, now in contrast to Parkinsonism, individuals with Huntington disease often have chorea, which are involuntary, random, rapid, dance-like movements, or athetosis, which are slower, writhing, snake-like movements that mainly affect the hands. They can also have psychiatric symptoms like depression, psychosis, or aggressive behavior. Death usually occurs within 10 to 20 years of diagnosis, often by aspiration pneumonia on account of discoordinated swallowing, or by suicide. For the test, remember that individuals with CJD have a long incubation period, but after the onset of symptoms, individuals develop rapidly progressive dementia within weeks to months. It's also classically associated with ataxia, which is defined as lack of coordination of voluntary movements, and myoclonus, a jerking movement of a muscle group. Hiccups are an example of myoclonus. In CJD, the myoclonus is usually generalized and can be triggered when the person is startled, and that's why it's referred to as startle myoclonus. CJD eventually leads to death since there's currently no cure. Finally, for NPH, remember that it affects the elderly and symptoms can appear over a month and presents with dementia, urinary incontinence, and gait disturbances. Their gait is described as magnetic because it seems like the person's feet are glued to the ground. Alright, now let's move on to diagnosis. The Montreal Cognitive Assessment, or MoCA, or the Mini Mental Status Examination, or MMSE, can be done to assess orientation, registration, recall, attention, and language. For your exams, it's helpful to remember how each of these cognitive domains is assessed. For example, orientation is assessed by asking individuals what time it is, where they are, or who the president is. Registration is assessed by telling the individual 3 words, like dog, table, and cake, then asking them to repeat it immediately. Then they're asked to repeat those 3 names 5 minutes later, which assesses recall, or short-term memory. Long-term memory is assessed by asking the individual details about significant events in his or her life. For example, the date of their marriage. Attention, or concentration, can be assessed by asking the individual to spell a word backwards, or recite the months of the year backwards. Language is tested by asking the individual to name presented objects, or repeat a phrase. Additionally, individuals are asked to obey a command written on a piece of paper, such as pick up the pen on the table. Comprehension is assessed by asking the individual to follow a 3-step command, such as take this paper, fold it in half, and place it on the table. Finally, individuals are asked to write a sentence and copy an illustration, such as a pentagon. The MMSE totals to 30 points, and a score of less than 24 implies cognitive impairment, which may suggest delirium or dementia. A very high-yield concept is how to differentiate the two. Delirium is usually acute in onset, lasts only a couple hours to days, and the cognitive symptoms fluctuate, meaning they come and go. On the other hand, dementia is usually gradual in onset, lasts months to years, and the cognitive symptoms usually progress over time. Also, consciousness and awareness are always impaired in delirium. However, they are only impaired in the later stages of dementia. Additionally, delirium always occurs as a direct physiological consequence in the event of acute insult, such as an infection, electrolyte imbalance, change in medication or intoxication, or due to a psychiatric condition like schizophrenia or depression. Now, after the diagnosis of dementia is made, it's important to find out if the cause of dementia is reversible, so treatment can be started before permanent damage occurs. So, it's helpful to send off TSH levels for hypothyroidism, vitamin B12 levels to assess for a deficiency, and a rapid plasma reagent test, or RPR, for syphilis. For NPH, a brain MRI shows ventriculomegaly of all the ventricles, a patent cerebral aqueduct, and no signs of cortical atrophy. As suggested from the name, a lumbar puncture will show a normal opening pressure. Okay, now on to the irreversible causes of dementia. The presumptive diagnosis of Alzheimer's disease is made clinically, and investigations are done to exclude other causes of dementia. For your exams, it's important to know that even in these early stages, a brain CT or MRI can show hippocampal atrophy that can progress to diffuse cortical atrophy. As the brain atrophies, or shrinks, the gyri get narrower and the sulci get wider, and the ventricles get larger. Enlargement of the ventricles due to brain atrophy is referred to as ex vacuo ventriculomegaly. A brain biopsy showing extracellular amyloid plaques that stain with Congo red and intracellular neurofibrillary tangles is the only investigation that would definitively diagnose Alzheimer's disease. But that usually isn't done until there's an autopsy after death. Vascular dementia can be diagnosed using brain imaging, most commonly CT or MRI, which will show multiple cortical and subcortical infarcts and changes like atrophy of the brain cortex, confirming the ischemia. Diagnosis of frontotemporal dementia is also based on a brain CT or MRI of the brain, which shows atrophy of the frontal and temporal lobes with narrower gyri, wider sulci, and ex vacuo ventriculomegaly. The parietal and occipital lobes are typically spared. Diagnosis of Lewy body dementia is based on the pattern of symptoms. Onset of dementia less than 1 year after Parkinsonism, along with vivid visual hallucinations, indicates Lewy body dementia. But the diagnosis of Lewy body dementia can only be confirmed with a brain autopsy that shows Lewy bodies in the neurons. Now, to diagnose Parkinson's disease dementia, you first need to diagnose Parkinson's disease. This requires the presence of bradykinesia in addition to one of the other trap symptoms, and ruling out other potential causes. However, the diagnosis can be confirmed with a brain autopsy that shows Lewy bodies in neurons, like in Lewy body dementia, and also the presence of depigmented dopaminergic neurons in the substantia nigra. Huntington disease should be suspected in an individual around 40 years of age with dementia, movement disorders like chorea and athetosis, and psychiatric symptoms. The combination of these features in a young individual can be mistaken for substance abuse. Family history of a first-degree relative with Huntington disease is a very important clue. The diagnosis is confirmed using polymerase chain reaction of the HD gene, which shows the CAG repeats. MRI imaging of the brain characteristically shows atrophy of the caudate and putamen and ex vacuo ventriculomegaly. On a brain MRI, CJD classically shows enhancement of the basal ganglia and thalamus, and EEG shows periodic bursts of high-voltage sharp waves. The combination of the clinical presentation and these investigations is usually sufficient to diagnose CJD. If a lumbar puncture is done, there may be elevation of protein 1433. Ultimately, the definitive diagnosis of spongiform encephalopathy is done after a person dies with a brain biopsy. Brain biopsy shows intracytoplasmic vacuoles that transform into cysts, giving the characteristic spongy appearance of the gray matter. Okay, now let's discuss treatment. The good news is that reversible causes can be treated and the dementia will usually go away. Alcohol dependence can be treated with medications like acamprosate, disulfiram, and naltrexone. Hypothyroidism can be treated with thyroid hormone replacement. Vitamin B12 deficiency is treated with vitamin B12 supplementation, and syphilis is treated with penicillin. The treatment for NPH is placing a ventriculoperitoneal shunt, which drains the excess cerebrospinal fluid. However, although placement of a ventriculoperitoneal shunt helps improve walking, it doesn't always improve cognition. Now, about the irreversible causes. Low acetylcholine levels contribute to Alzheimer's disease, and so cholinesterase inhibitors like donepezil, rivastigmine, and galantamine can be used for treatment since they increase cholinergic transmission at the synaptic cleft. In individuals that can't tolerate cholinesterase inhibitors, NMDA receptor antagonists, like memantine, can be used. These medications don't slow the progression of the disease, but they do help mitigate some of the cognitive and behavioral symptoms like forgetting family members or personal info, making day-to-day life relatively easier for affected individuals. Finally, depression is common in all types of dementia, but especially in Alzheimer's disease, and selective serotonin reuptake inhibitors, or SSRIs, are an effective treatment option for behavioral symptoms, although they don't improve cognition. Unfortunately, there is no available treatment that can help reverse vascular dementia. Instead, treatment mainly focuses on preventing another stroke from happening. This includes blood pressure, diabetes, and cholesterol control, lifestyle modification, such as exercise, dietary changes, and smoking cessation, as well as starting antiplatelet agents like aspirin. In vascular dementia, the evidence is mixed for the cholinesterase inhibitors, but they're often prescribed because of the frequent co-occurrence of cerebrovascular and neurodegenerative disease. There is no current treatment available that will help delay the progression of frontotemporal dementia. However, selective serotonin reuptake inhibitors can help with the behavioral symptoms, and atypical antipsychotics can be used for the psychosis. Okay, now in Lewy body dementia, treatment is aimed at alleviating motor symptoms. These symptoms respond to drugs used to treat Parkinson's disease, like levodopa, a dopamine agonist. However, individuals with Lewy body dementia are dopamine sensitive, meaning that dopamine agonists can cause them to have hallucinations, agitation, and confusion. This unique reaction is also a clue that the person has Lewy body dementia. Also, although it might be intuitive to give antipsychotics like haloperidol or risperidone for the visual hallucinations, these medications should be avoided in Lewy body dementia as they can worsen Parkinsonism. Now for Parkinson's disease dementia, rivastigmine, which is a cholinesterase inhibitor used for Alzheimer's disease, is approved along with the medications used for Parkinson's disease, like carbidopa-levodopa, and dopamine agonists like pramipexole and ropinirole. These will help motor symptoms, but will not reverse or slow the course of the disease. As for Huntington's disease, there is no treatment that affects overall survival. However, medications that decrease dopamine levels, like the neuroleptics, which are dopamine receptor antagonists, and tetrabenazine, which deletes dopamine, are used to treat chorea. Unfortunately, there's no current treatments for CJD, and so prevention of transmission is a key management strategy of the disease. Alright, as a quick recap. Dementia occurs when there's a decline in cognitive domain like memory, language, or executive function, causing impairment in daily functioning. Dementia can result from reversible causes like alcohol dependence, hypothyroidism, vitamin B12 deficiency, neurosyphilis, and NPH. But it usually results from irreversible causes, such as Alzheimer's disease, which is by far the most common cause of dementia, vascular dementia, frontotemporal dementia, Parkinson's disease dementia, Lewy body dementia, Huntington disease, and Creutzfeldt-Jakob disease. Dementia can be diagnosed based on symptoms. Clinical tests like the Montreal Cognitive Assessment or the Mini Mental Status Examination. The causes can be identified by symptoms specific to the disease, imaging tests like brain CT or MRI, and more definitive tests like a brain biopsy during an autopsy. Okay, back to the patients. So, Oliver, due to his age and the history of behavioral symptoms with relative sparing of memory, most likely has frontotemporal dementia. Diagnosis can be confirmed with a brain CT or MRI showing atrophy of the frontal and temporal lobes. Iris has a characteristic triad of NPH, urinary incontinence, magnetic gait, and dementia. Brain MRI will show enlarged ventricles with no signs of cortical atrophy. Also, a lumbar puncture will reveal normal opening pressure. Fortunately, NPH can usually be reversed by placing a ventriculoperitoneal shunt. Finally, due to Alistair's young age, history of rapidly developing dementia along with myoclonus and ataxia, and history of corneal transplantation, Alistair most likely has iatrogenic Creutzfeldt-Jakob disease.
Hey, congrats! You got accepted to med school. Nice. So now that you're in, how do you succeed? They say that learning in med school is like drinking from a fire hose. In other words, it can be overwhelming. But don't worry, because there are 4 basic ways to make sure that you're in control. You can work on your study skills, create healthy habits, manage your money, and avoid getting overloaded with your options. Let's start with the study skills. In short, how you study is just as important as what you study. You might have made it through college by cramming the night before a test, but that's not going to get you through med school successfully. Unlike different subjects in undergrad, in med school the information builds on itself, meaning that just because you finish a class, you can't forget what you learned. So there are some proven learning strategies that you should take advantage of, like interleaving, where you mix up the order of what you learn, as well as spaced repetition, where you study material over different periods of time depending on how well you know the information. Both of these strategies help you retain information and maximize the effectiveness of your study time. It so happens that the Osmosis learning platform incorporates these strategies to make them an automatic part of how you study. Now, in addition, some students love studying in groups initially and then splitting off to work alone, whereas others like to do the opposite. The key here is to figure out what works for each class, and be willing to experiment until you feel like you have an approach that works. Alright, so next you should make sure you develop healthy habits. Days will get busy when you're in med school, so it's important to get plenty of sleep, exercise, and eat healthy food to keep you performing at your best. Also, you can't study all the time and not expect to burn out. So make sure you have a support system that you can turn to for help when you need a break. Spending time with friends and family, talking to a trusted mentor, or getting outdoors are great ways to reduce stress and can help recharge those batteries. Now, it's impossible to talk about med school without discussing money management. Unfortunately, the costs do add up quickly. Tuition, housing, textbooks, medical tools, board exams, and all the other costs of day-to-day living. The median debt of a US med student after graduation is close to $200,000. Every dollar you take out now, you'll have to pay back with interest later. So be savvy about your spending. Look for ways to reduce your expenses, like living with a roommate, or choosing more affordable housing and cooking at home. The bottom line is that every dollar counts. Finally, it's easy to get overloaded by options. You might be tempted to immediately dive into a lot of different activities, like research, advocacy work, clinical work, sports, or community service. It's really hard to fit everything in. So don't be afraid to take your time and figure out what really matters to you. And don't feel bad about saying no to someone or something, even if it seems really rewarding. Your time is precious, and you should save it for the things that you value most. So, congrats again on your acceptance to med school. But as you prepare, just remember to think about your study skills, forming healthy habits, money management, and avoiding option overload. And you'll have an awesome first year. A memory palace is a type of memory technique where you imagine a physical location to help you remember more abstract information. The reason that memory palaces work is that our brains are better at remembering images and locations, as opposed to abstract things like names and numbers. Let's start with an example to show you how this works. Let's say that you're trying to remember the 6 drugs or drug classes that are known to cause pancreatitis, or inflammation of the pancreas. The list goes diuretics, corticosteroids, alcohol, azathioprine, didanosine, and valproic acid. First things first though, you have to ask yourself, is this something that's worth remembering and is the learning objective clear? Clinically, it's really helpful to have these 6 drugs or drug classes in your working memory, so that you can spot them on a medication list and think about them as a potential cause of pancreatitis. So if you decide it's worth remembering a list like this using a memory palace, you've got to start with picking a place that you're familiar with, like a bedroom. It doesn't have to be a bedroom though, it could be any place you know, like the gym, a store, or some place you've seen or imagined like in a TV show like The Office. Next, you can start identifying specific spots called loci in that place. It's nice to pick really distinct spots, and in this case we'll pick out 6 spots because there are 6 things to remember. Let's go with the bed, the window, the doorway, the dresser, the rug, and the ceiling light. Next, you have to create images for each term you're trying to remember. To do this, you can try a few approaches. First, you might go with sounds like. For example, papule sounds a little like papa and mule. So you might imagine an excited new dad riding around on his baby mule. Another trick is to go with looks like. For example, a parietal cell looks kind of like a fried egg. Finally, you might try seems like. For example, taking sedative medication and feeling drowsy seems like what a bear might feel while hibernating through the winter. But rather than try to analyze which trick you're using, you should simply use whichever image first comes to mind. So in our pancreatitis example, you might imagine someone urinating all over the sheets to help you think of diuretics on the bed, a huge steroid-using bodybuilder smashing the window to think of corticosteroids in the window, a drunk person missing the doorway and running straight into the wall for alcohol in the doorway, maybe Aslan the lion from Narnia hiding in your dresser drawer for azathioprine, maybe a Titanic sinking into the fuzzy rug for didanosine, and finally for valproic acid, a valiant Professor Indiana Jones swinging from the ceiling light. The more unique and descriptive the image, the better it will stick, because our minds love to hang on to interesting visual images in familiar settings. So that's how it works. The Memory Palace provides a scaffold for abstract information, and over time it can help your brain organize and connect concepts. And don't worry if you're not good at drawing, because you actually don't have to draw anything out. You can simply just imagine it, and it works just as well. With this technique, you learn faster while forgetting less, and creating the images themselves makes learning more enjoyable and adds a little flavor to the usual study routine. In terms of making a memory palace, it's always important to pick the right material to apply this learning tool. Typically, you want to pick something where the learning objective's really clear, like learning the steps of a process or a list. Making your own memory palace can take time, but studies suggest that it's worth the effort, because the memory palace is more personalized and therefore easier to remember. Having said that though, the difficulty of the material really matters. And for difficult information and concepts, really well-crafted memory palaces are likely to be more accurate and higher quality. So given the availability of great resources for memory palaces, the ideal situation for a student might be to make simple memory palaces themselves and use existing well-crafted ones for tough material, until they feel ready to take on those challenging topics themselves. Alright, as a quick recap of the causes of pancreatitis, take a second right now and try to think of the 6 drugs or drug classes that can lead to pancreatitis.
All right. How are you feeling today?
Hey guys, Rishi Desai here from Osmosis. Thanks for joining me again this week. What I wanted to talk about this week were study tips, top 3 study tips from my own life, things that have helped me, and things that I think don't work quite as well, that I kind of stumbled across and kind of figured out as I went along. As background, I'm the Chief Medical Officer at Osmosis, and I'm a pediatrician. I do pediatric infectious diseases. And so I've had kind of a very traditional route in some ways, going into medicine, and in some ways a very non-traditional route, because I do a lot of medical education. And so for me, as I was thinking about studying, I thought, honestly, I would say I'm kind of a professional studier. Every single day I come in and I'm making videos or questions, and I'm looking up things. And so I'm literally constantly learning, constantly studying. And so I think studying itself has become, for me, something that I really pride myself on and take a lot of enjoyment out of. But it took a long time to get there. There was a lot of time when I was studying and I hated it. I thought I wasn't doing it right. And I probably felt that way because I wasn't doing it right. Here we go. Number 1. So for me, it starts with where. Big question. Where? Where do you like to study? And it's location, location, location. It's everything, right? So, it could be the corner spot in the library. Maybe you're that kind of study. Maybe it's the coffee shop. You like that aroma. Maybe it's your friend's apartment or your own apartment. Or maybe you have a desk set up. For me, I actually came back to my childhood home of studying. This is where I got a lot of my studying done. So that's why I thought it'd be kind of fun to come back here to kind of get back in that spirit of it. And I actually came back here through college. I would take breaks, come back here on weekends. When it came down to medical school, I was about 5 hours away. So I actually drove down here to study for boards. And the reason location matters, this is the key here, is that it really controls your environment. So I would come here because I got my peace here, my quiet here. My parents, stepped up. They did a ton of stuff to pamper me, frankly. Laundry, cook meals, all the kind of logistical stuff I didn't have to think about. So I could literally just kind of focus, right? And that's what you really want to do, is focus, recharge your battery, not get distracted by 1,000 decisions you have to make every day, and really apply your focus to the thing you need to focus on, which is just learning new material. So that's really, really crucial. That kind of important piece is location. And so that first question again, where do you like to study? That's the first tip. Choose it, pick it, know yourself, and make sure you keep going back there, or mix it up if that's what you need to do. Number 2, big tip number 2 is what? What are you going to study? And this is the biggest thing I notice. I'll go to study with someone, a study date or a friend, and I'll say, hey, let's go study. And we'll sit down, and that other person is literally just kind of twisting their thumbs, kind of like dawdling around, and you're like, what are you doing? And they're like, I'm not really sure what I want to do yet. I haven't figured it out. And they'll literally spend 30 minutes, 45 minutes, like figuring out what they want to study. And so for me, I try to figure out what I'm going to study, as I wake up that day. I have in my mind kind of my intention for the day. What are my goals for that day? What do I want to get out of it? And so know what you want to study. And the way to figure that out, one way, if you're not sure, is spaced repetition. I can't say it enough. Spaced repetition. Spaced repetition, right? So I'm repeating the word for you. I hope you remember that term. And the idea is that you go over the stuff that you've learned in the last 6 months, right? Maybe flashcards, stuff that you haven't looked at in 6 months that you're getting right, stuff you're getting wrong. It literally refreshes your mind. You start thinking about all the stuff you've learned. It's like going into the field and aerating the soil, getting all that hard clay up that was maybe settling down at the bottom, and saying, hey, what is this stuff I really struggle with? And thinking, what are the 2 things I want to learn today? That's what I want to figure out. What do I want to learn today? And for me, it's always kind of the things that I'm scared about, things that I don't want to think about. So let's say that's renal physiology, or learning about autoimmune diseases, because they all gonna kind of get confused in my head. Or stuff I'm curious about. Like, hey, I really am super curious about such and such. Someone said something, I thought it was interesting. I didn't really get it, so I'm really curious to learn more. So what is the stuff that you're kind of worried about and stuff you're curious about? That's the stuff I really think that you need to focus on. So that's the what. Tip number 3. So now we know where we are. We know what we're going to do. How are you going to study? And this is, people have 100 different answers for this. My answer, what's worked really well, is you start with questions. Don't go and start watching videos. Don't go and start, reading a book or reading notes, because you're reading passively. You're not reading to actually learn. You're reading just to get through the chapter. You're reading just to get through the video. Don't do that. It's a waste of your time. It doesn't work as effectively. So there's this idea called a testing effect. And what it means is you go in, you do some questions, and I don't care if it's stuff you've never looked at before. Even in that situation, go do a question. And questions on Osmosis are organized that way. So you can just dive in, do some questions. and identify what it is that's confusing. Could you figure it out? Did you read the explanation? Did it make sense? Start kind of getting your mind into that active mode by saying, hey, you know what? I didn't answer this question right. I couldn't figure it out. Now I'm searching. Now I'm on the hunt. I'm hunting for an answer. Now, once you've identified stuff you're kind of struggling with, you say, okay, look, I thought I wanted to focus on renal physiology based on my space rep. I went in, did some renal physiology questions. I got basically all of them wrong. No surprise, right? But at least now you know the specifics. Oh, okay, it was about ions. I couldn't figure out how the ion channels worked. Okay, great. So now that's where you start saying, okay, what is the best resource for renal physiology? What's the number one topic or place I want to go? Do I want to go read a book? Do I want to go and look at some videos? Do I want to go watch, some memory palaces? Like, what do I want to do to really understand how the kidney works normally? Okay, great. Make a list. Figure out how long that list is. How many videos is that? Calculate time and say, okay, this is about 1 hour of time, right? This is my hour of power. I've figured out where I want to study. I figured out what I want to study. Now I'm figuring out how I want to study. And I know that these are the things I want to look at. Go through those, watch those videos. Maybe it's an hour of videos, double speed it. So that's only 25 minutes or 30 minutes. And say, okay, every 30 minutes, I'm going to give myself a minute break or a 2-minute break. And you just know that, like, hey, my break is coming. Just power through until I get to my break. And the thing that's going to drive you is the question, like, what was it that I couldn't figure out? So again, go through, figure out what you want to learn, dive in, watch those videos, read those parts of the textbook, really understand it well, and then you can say, okay, good, I got it, I'm all set, I'm ready to move on to maybe more questions, or maybe I've finished my 2 goals for the day, I'm ready for a 3rd goal, or maybe I'm ready for a thing of ice cream, whatever it is. So once you challenge yourself with a couple of goals, you master it through that hour of power, watching those videos, reading those bits of the textbook, go back and do the questions, make sure you understand them, you really feel good about them. Then you've studied, you really understand it, and then down the road when you're doing spaced repetition, maybe you will actually get those questions right because you actually spent such dedicated time to that. So those are my 3 tips again: where, what, how. And then a little bonus tip: if you're doing these kind of things, you're obviously interested in becoming a better student, right? That's part of your ethos. Just know that about yourself. And if you're interested in being a better student, in addition to watching these tips, a little bonus tip is we actually put together this. So a little how to learn in the health professions. My team and I worked on this. It's an incredible resource. Tons of great little images and visuals. Go over kind of testing effect, spaced repetition, and a number of other tricks and strategies that work. So check that out. And again, leave a comment. Tell me what works for you. Make it specific. The general stuff doesn't help anyone, so make it really specific. Where do you like to study? What do you like to study? How do you like to study? And then finally, lest I forget, you should study. Make a study schedule. Go on osmosis.org, set up your study schedule, and I'll check you out again maybe next week. Take care. Bye, guys.
Start your free trial today at osmosis.org.
A memory palace is a type of memory